Okay, can I call the first speaker, Dr. Vernon Vello, who will talk to us about management of intraventricular tumors.
Thank you, Chairpersons. I'd like to thank Professor Ishwaran and his whole team from Chitra and also Professor Suresh Nair for this kind invitation. And it has been a pleasure these last 2 days being with you all. So my talk for today is going to be management of intraventricular tumors. So this is the place where I work, and coming to intraventricular tumors, they only form around 0.8 to 1.9% of all tumors, and most of these tumors are histologically benign, so you got to go chasing them. And there are two types of tumors basically. They are primary, which arise from the ventricular wall, and then we have the paraventricular tumors, which behave like intraventricular tumors. So the primary tumors on your right side, the colloid cysts, papillomas, ependymomas, craniopharyngomas, meningiomas, and inflammatory lesions. And the secondary tumors are meningiomas, gliomas, which invade into the ventricle. So the workup, basically what you require is a complete workup, because the plan is very important. And we have the CT brain, which is important, MRI with contrast, DTI, and the MR venography also helps, especially when you're doing the transcallosal approach or the interhemispheric approach. And the neuropsychological and ophthalmology checkup is also important. What are the goals in management of these tumors? You got to choose the most favorable trajectory, adequate exposure, resection of the entire lesion. Leaving half a lesion can create more problems, so you should go in for the lesion totally. And the best proximal control to major feeding vessels should be attained. Be careful of the veins and also respect the CSF pathways. So a thorough knowledge of the anatomy is very important. And one should have a 3D imaging in your mind when you're going into the ventricle. So these are the different approaches one can see here. So the approaches are different depending upon where the tumor is situated. One can go supratentorial, one can go infratentorial, but one has to plan and choose the approaches appropriately. So these are the approaches, frontal horn approaches. Then tumors involving the body, you can go transcallosal. Atrial tumors are transtrigonal, and entry corridors to the ventricle are also important, because these are all eloquent areas sometimes when you're operating on the left side. And the approaches to the third ventricle depends upon where the tumor is situated. If it is more anterior, you can go subfrontal, or you can go interhemispheric. And the corridors basically are interoptic, opticocarotid, lamina terminalis transfrontal, or lamina terminalis rostrum callosum approach. So just to show you some examples, this is a classical colloid cyst where we go transcallosal. We use the ultrasound to localize the tumor so that we can open the callosum right at the level of the tumor. You don't have to open too much of callosum. And I don't use retractors. We've stopped using retractors. If you're using it, just use it just for during the time. We use the silicone paddy, and we also use Merocell. Take 2 pieces of Merocell, put them in anteriorly and posteriorly, and inject saline, and there is enough of retraction which you get. So we have entered the ventricle now. A gradual dissection of this capsule is important, because these capsules are adherent to the choroid plexus and the choroidal vessel, so one has to be careful. We used to do these cases endoscopically. I have stopped. I prefer to do the transcallosal because the excision is better. Endoscopic, you end up leaving a remnant and the chances of recurrence. So once the tumor is dissected all around, so avoid unnecessary retraction, especially self-retaining. It produces traction on the vein. And one can disconnect the tumor by sharp dissection. We also leave a catheter for 48 hours to get rid of any colloid material or any blood. So that's the excision in toto. And that's the patient, that's the post-op scan. So this is another patient, slightly difficult. This patient had a craniotomy and craniectomy done for a subdural hematoma. He came with this, and then we went in transcallosal, but it was not that easy. So we again used the ultrasound to localize. This case is similar to the previous case, but here the ultrasound is important because there's adherent brain below, because he's already operated once, and the corpus callosum is totally thinned out, if you see. So in this patient, we had a difficulty, although with ultrasound, we had a lot of difficulty getting to the corpus callosum. That's the cyst which is seen beautifully on ultrasound, and we use the ultrasound by default for most of our cases. So here we wanted to go interhemispheric, but the corpus callosum was very deep, so we had to go sort of paracallosal. So I just want to show you that sometimes there are bridging vessels, bridging veins which come across, and especially when the brain is adherent, there is no space to go in. So here what you can do is you need not coagulate anything. You just have, there's something called as hemopatch which is available now. It is activated collagen which can be used, and that bleeding stops and one can proceed with the surgery. So here we are showing that. So as we were doing this, you see there's a draining vein here. So one should not coagulate this if it bleeds. It's bleeding. So we just put this hemopatch, and then one can control the bleeding, and then we can proceed with the same surgery. Here the fornix was slightly adherent to the tumor, so we tried callosal first. We put this merocell. We could not reach the callosum because if the callosum is thinned out, it becomes difficult. So we went paracallosal. So we used this silicone patty for dynamic retraction. But we could not just reach there. So we had to change our plan and go transcortical, paracallosal. So here we are localizing it with the ultrasound again. And that's the anatomy. Once you get into the ventricle, then the excision is the same as I'd shown before. So one has to be ready with a plan B. Sometimes you cannot go transcallosal, and then you have to be ready for a transcortical. And the craniotomy should be planned away. Here we are splaying the fornix a bit because the tumor is stuck here. And so again, no retractors, because retraction here creates a lot of traction on the veins, and by the time you have finished this surgery, then the veins have snapped off and becomes a big problem because of the ventricles which collapse. So as far as possible, less retraction. So that's the last bit coming out, and that's the tumor. So this is the post-op. He had a post-op tracheostomy, which he had to be kept on ventilator for some time. So these patients sometimes do have a long recovery time. So this is the third ventricular glioma. Due to want of time, I'll skip this because Dr. Matthew will be talking on these. Okay, this is the post-op scan. This is central neurocytoma. Again, I think Dr. Matthew will do this part. I will not show these. I'll go straight to the meningiomas now. Meningiomas are a different ball game. This is a large, where I reached somewhere else. Okay. So this is how we localize. And they are pretty tough tumors. They are stuck. And sometimes you need to use scissors. You need to use the knife. And they're calcified tumors. And here we had to use even a ring monopolar cautery to cut it because it was pretty firm. So the important thing in the intraventricular surgery is to keep on getting oriented. The tendency is to get disoriented once we are in the ventricle. We lose the orientation. So we have to keep getting oriented. And I think my time is over, so I will have to just Go quickly. This is the post-op. So this is another meningioma operated post-op. This is a craniopharyngioma which we did transchoroidal, transcallosal. I think Sri Chitra also does this approach. So here we went, the tumor was more into the third ventricle. So we went transcallosal, transchoroidal to excise this tumor. So we are going through the internal cerebral veins, through the choroid fissure, and we could get the whole tumor out. So that's the post-op, that's the patient. So subadenyomas, pre-op, post-op. So epidermoids, different ball game. One has to choose the proper trajectory, and these are large epidermoids. I don't know why I'm skipping. I'm going more for. Okay, this was a large epidermoid. So which we went again, transcallosal, interhemispheric. So this tumor was going from the supratentorial to the infratentorial compartment, but the good thing about epidermoids is they pave the way. You have to just follow the epidermoid and you can get it out completely from the posterior fossa also. So I prefer to take out the epidermoid in one piece as much as possible so that you do not disapponate the epidermoid. So as much as capsule should come out. And that's the endoscopic view after removal of the tumor. And that's the third ventriculostomy done. We are in the prepontine cistern. That's the post-op scan. So I'll just, so these are some tumors which we have operated. So this is a large choroid plexus papilloma, but I think due to want of time, I will skip this. Similar way, this is the post-op scan. I'll just show you one pineal. So we operate it in this lateral sitting position. This is a pineocytoma. So basically you get the same effect like the sitting position. It's good for the surgeon because the patient is very close to the surgeon, so no pain on the arm. This tumor was sort of anterior to the veins, and we do not use retraction again because it puts too much tension on these veins, so we have to be careful and preserve all these veins as much as possible. So here the tumor is anterior to these veins, so we got to find the corridors in between the veins to get this tumor out. So here we would be taking a biopsy, and then we would be going all around, entering the third ventricle posteriorly to get this tumor out. The difficult part is the posterior inferior part of the tumor. Yeah, I'll just stop after this video. Just to show you that you can do it, especially in adults, you can do it nicely with the lateral sitting position, and that's the fluoroscreen. And try to preserve all the veins as much as possible. This is the posterior inferior part which is coming out. Hemostasis, and the endoscopic view is good. You can see with the endoscope, and you can remove some blood also which is there in the aqueducts. So post-op, this is the patient. They have a stomy recovery, but they do well after excision. So I have some other tumors because due to want of time, I'll conclude now. So just to complications, you have to be worried about them and you should take care. And also the outcome is good if you excise these tumors totally. So technical difficulties are there, you have to be careful. And to conclude that they are difficult to approach, but one has to have a proper plan and the plan also, and have a plan B if the plan A fails. Thank you.
Thank you. Thank you so much, sir. You have excellently demonstrated how you can use ultrasound, microscope, and to do all these complex procedures. I think we will do the discussion at the end. May I call upon the next speaker, microsurgical management of thalamic tumors, Professor Matthew Abraham.
Suddenly it has stopped. Yeah, it's connected. Okay.
It's on.
Respected teachers and dear friends, surgery for thalamic tumors. If you see this is actually a very big and complex field, and it's working. Okay, I'll manage some more. The thalamus is a very important association and projection zone, and this, for most of us, it may appear as a one single entity. But the thalamus is a very central core area which has to be approached from different trajectories. There are several challenges involved when we manage a thalamic tumor. The blood supply to the thalamus comes from the posterolateral aspect predominantly, as well as from the base. The continuation of the brainstem continues in the form of a Y-shaped structure, that's the internal medullary lamina, which carries most of the ARIS through it. And the lateral surface of the thalamus is virtually inaccessible because of its close association with the reticular nucleus. There are some basic principles. I'll rapidly zero down on the principles because I have a great shortage of time. The only lesions of the pulvinar, the medial and lateral geniculate body, medial and anterior thalamus, and perhaps the lateral posterior and lateral dorsal are perhaps operable. We have to decide which zone of the thalamus we are going to attack. You can't attack every region from one trajectory. And the exact trajectory for that zone has to be chosen, keeping in mind the internal medullary lamina. You can't breach the internal medullary lamina because the patient will have a neuropsychological as well as sensorium deterioration if you breach that. In fact, the entire hemisphere gets disconnected if you cross through the lateral aspect. No dissection should occur perpendicular to the perforatus of the PCA. And most often, except the inferior and anterior and some medial, they're not good for any relook surgery. This is my personal series for intraventricular tumors. That is, when it comes to diencephalic tumors, I have operated on approximately 237 cases and around 124 thalamic gliomas. I have divided them into four categories. It's the posterior thalamus, medial thalamus, inferior thalamus, and the lateral thalamus. If you see, the lateral thalamic lesions are very few because most of them present in a quite bad shape. It is actually the posterior thalamic lesions, so the pulvinar lesions, which actually are the excellent surgical candidates. So this is around 72 cases I have operated on. I'll just briefly show a video. This is the inferior parietal lobule approach, popular. Most of us are used to this approach. It is preferred on the right side, on the non-eloquent side, for reasons of language preservation. As soon as you enter the ventricle, you have to still maintain your orientation so that you can see the lesion. You can perceive the lesion. You may not see. Intraventricular tumors, you may not directly see the whole extent of the tumor. So you have to perceive the structure as well as the normal structures. Right. Recusa is invaluable, and you can differentiate when the tumor gets over because the interface is most often clear. Actually, this approach is very similar to an EVD. Only thing, you have expanded the EVD trajectory into a wider axis. It is quite possible to get radical total excisions. In fact, it's better to remove everything in one go because a second approach is not often easy. This is one of the post-operative scans of this patient. This patient was undergoing the surgery. And this is another, one of the presentations of a pulvinar lesion will be loss of prosody, inability to do coordinated tasks. This girl had presented with it's a class topper, school topper, presented with difficulty in writing. After one word, she has to stop, pause and go for the next one. Plus her prosody of speaking as well as all coordinated activities were affected. She could move around, but she could not do more than one step at a time. This is a post-operative video. We have approached the same inferior parietal lobule approach. And this is a post-operative video at 8 weeks post-operative. The coordinated activities returned promptly. And actually her flow of speech also, there was a remarkable change in the way she could speak and write. Do you have a sound in this? No, that's fine. That's fine. So if it is on the dominant side, the approach changes. You can't use the inferior parietal lobule in most circumstances. You may have to go for a longer or slightly more, marginally more difficult approach. That is the superior parietal lobule. The advantage is that it's in a watershed territory. The chance of devascularization is less. This is one of the post-operative scans. When it comes to the medial thalamus, the approach is actually totally different. You can't go from posterior to the medial. You will have to approach from midline. So this is one midline lesion. This is a very prolonged video. Unfortunately, I will not be able to cover this lesion. Is my mouse working? No. Can I scroll on this? No. Okay. That's fine. That's okay. No, not required. No longer. So this is a midline lesion which has been approached. You can see it has been radically removed. This is another one. So when it comes to the inferior thalamus, the concept of the inferior thalamus is slightly, it is actually closely related to the optic tract lesions. You can see it lies on the inferior aspect. It arises mostly from the lateral geniculate body. They look large. They seem to be coming very close to the capsule. So we have devised an approach that's a transchoroidal. You use the trajectory of the choroidal artery to approach it. You have to work between the vessels and never be perpendicular to them. This is a problem. No, the problem is this one does not appear. The navigator does not appear. The navigator on this one does not appear. I can't push it forward. That's okay. Again, this is a little prolonged video. I think I'll skip that. So this is one scenario. It's not moving. I'm unable to move the video. Unable to move the slide. This is the slide I'm unable to move. Okay, so this is the post-operative scan of this patient. Although the capsule as well as the brainstem appears involved, most often you will be able to preserve it if the patient does not have a pre-operative deficit. This is the kid at 6 weeks. She had presented with hemiplegia. She was bedridden and had difficulty in a small gaze preference was also there. So we thought it may be a cortical involvement also. The thalamus sometimes produces some degree of cortical dysfunction. She made a prompt recovery. That is me standing and talking on phone behind. So this is one lesion which can be staged actually. Some of these larger lesions, they look as if they are close to the capsule, involving the capsule. You can actually decompress them. The arachnoid cap around, some form of a cap may actually push the lesion downwards. And this is the post-operative scan. This is a two-stage resection. This is a child 7 years post-resection. This is one of my first inferior transchoroidal approaches that I have done. The child does not seem to have any form of capsular defect. That is, she's demonstrating her pyramidal tract. So this is the lateral thalamic lesions. Already it has been, this approach has been published by Dr. R.C. Mishra. You can see it is only for the posterior lateral aspect you can use this. It's a transinsular approach. You open the sylvian wide, go behind as much posterior as possible so that you don't go to the posterior third of the capsule. The retrolentiform and sublentiform capsule may have to be traversed. You need maximal exposure of the insula in this case. You have to reach the insular point. That's the deepest and posteriormost point. So that is the region, posteriormost insula and the angular artery. If you are more anterior, you will be directly traversing the capsule. The lesion is showing itself. So this is the post-operative scan for this lesion. Now, to summarize, when it comes to the anterior thalamus, an anterior interhemispheric transventricular approach is preferable. Some of the tumors can be approached subfrontally, but that's quite rare. The medial thalamus transcallosally, interfaunicially through the third ventricle. The lateral thalamus, most of them are not resectable. They present with hemiplegia. The posterior insular approach is for the posterior region of the lateral thalamus. The posterior thalamus is the most accessible region and perhaps present with large lesions, and a trigonal approach on the dominant side of superior parietal and on the non-dominant inferior parietal approach. And for those inferior lesions, that's those arising from the lateral geniculate nucleus, quite common, you can go for a pterional subfrontal approach. Thank you.
Thank you, Dr. Matthew, for that excellent demonstration of how to handle these tumors in the thalamus. Our next speaker is Dr. Manjul Tripathi, who will tell us about radiosurgery for small vestibular schwannomas, whether to wait and watch or whether to radiate.
Thank you, Chairpersons, and thank you, organizers, for giving me this wonderful opportunity to come to the Rout Oration. And this is going to be the next Aruba, whether to treat or whether you can just leave the tumor behind and just observe it. So I am here in capacity of a microneurosurgeon and radiosurgeon, and this talk is specific only for the sporadic vestibular schwannomas. I am not going to touch the syndromic vestibular schwannomas in this talk. So the axiom of rarity shows that the clinical controversy is inversely proportional to the incidence of the disease, and with the current pace we are going to add nearly 30,000 vestibular schwannomas in India per year. And since the introduction of SRS, you have an observation versus SRS option available for your patients, and you choose either of these two. Like with the varied fractured literature, the people come with a very varied opinion and varied sensitivity to your treatment options. Either they become overtly sensitive for your options or they become a completely resistant ones. With nearly 1,000 patients treated with gamma knife in PGI, and worldwide the option for a small vestibular schwannoma, the aim of the treatment is cessation of the tumor growth or stabilization, elimination of the open surgical risk, maintaining a good quality of life with a progression-free survival, and the patient satisfaction, keeping yourself medico-legally secure in line with the literature as well. Thanks to the mobile and the improved radiation, improved radiology, we are diagnosing these patients much more earlier now. Nearly 33% of the vestibular schwannomas are Coos grade 1, and most of them are either asymptomatic or post-asymptomatic. Hearing preservation. This was a consensus guideline published in 2017 with the CNS, with the whole of the literature available in the last 2 decades with them, and then they tried to find out what are the chances of maintaining the functional hearing in the preserved patients, either with observation or a single fraction SRS, and practically there was no difference on 2 years, 3 years, 2 years, 5 years, and the 10 years follow-up. Similarly, in patients with the Coos grade 1 hearing loss, the single fraction SRS versus observation were practically same in the long term. Then they evaluated what are the indication for the lesions without any evidence of the radiographic progression, because whenever there was a radiographic progression, that means that the tumor is growing, and they offered SRS to those patients. But if the patient is having no evidence of the radiographic progression, their recommendation was a level 3, that if tinnitus is not observed at the time of presentation, because tinnitus is a negative prognostic factor, if this is not observed at the time of presentation, then observation is a fairly good option for the hearing preservation. There are other good guidelines like the ENO 2019, which had a level 2 evidence in support of SRS and level 3 evidence in support of observation, was practically there was not much significant difference. This you can put on a biased opinion because this was by the radiosurgeons, and they thought that whenever there is a small vestibular schwannoma, whenever it is detected, because you are not born with a vestibular schwannoma, it was detected because some of the other reason or incidentaloma, then SRS is a 100% agreeable position for these patients, and 80% people were having observation is also a strong opinion. So the series which have the long-term follow-up with gamma knife, which are available only with the gamma knife, the LINEC are not giving any 5-year hearing preservation. The 5-year tumor control is nearly always more than 90%, and the hearing preservation is in the range of 41 to 79% depending on your technology and the doses to your cochlea. So in consensus, we can say that for small, newly diagnosed vestibular schwannomas without significant mass effect, observation and single fraction SRS both are equally strong consensus, but for growing vestibular schwannomas, SRS should be offered as a proactive treatment. You do not need to wait for these patients. But can I really trust these guidelines? Because most of them are the retrospective studies. There was no imaging parameter, uniform imaging parameter, because you are just evaluating on a CT or an MRI on the axial imaging. There was no volumetric assessment. SRS platforms, their technology, dose to the cochlea was different, and the criteria for growth is still not defined. So if you observe these patients, there are good long-term studies which show that you see your patients going deaf down the line 5 to 10 years. And if you look at the natural history of vestibular schwannoma on PubMed, there are nearly 170 articles. That means that this question is still open and we do not know. But if you do a comparative evaluation on an yearly basis with the 3D volumetric assessment, the growth rate has been found to be somewhere around 33.6%, and that means it makes a difference if your primary tumor volume is 0.2 or 0.3 cc or it is a 3 cc, because 33.6% would convert it only into 0.4 or 0.5, but for a 3 cc it would make a meaningful difference. So this robust study showed On a comparative evaluation each year with a strict follow-up with the 3D volumetric assessment, that 69% tumors had a volumetric growth at median 1.1 year follow-up. That's a significant growth. Any increase is actually a growth. We have known patients who do not grow, but they lose their hearing. So practically, we do not exactly know what causes the hearing loss, and there are multiple mechanisms behind it. It might be compression, secretion, vascular effect, and now coming TNF-alpha into the picture and the PD-L1, which might cause a patient losing the hearing without showing a remarkable growth in those ones. I give this study to the patients who want to know about it, if they can just wait and watch. And this is a very good study by the Marseille group. They show that the risk of failure is much higher in the wait and see group compared to the proactive GKRS, at least at the 1 year follow-up. So that's a short-term follow-up, but even in that, that's a significant difference in the hearing and the tumor control rate. This study showed the volume doubling time before treatment and after treatment for patients who were kept just on the observation. The volume doubling time before treatment was 1.36 years, but after gamma knife it increased to 13 years. That's a remarkable, nearly 13 times higher. And it shows that if you treat these patients early before in the time of their natural history, within 2 years of the diagnosis of the disease, your chances of long-term hearing preservation are statistically much significantly higher in the case control studies. But whatever the machine you use for it, your organs at risk are cochlea, especially the basal turn of cochlea, and then this led to an era when we were evaluating the dose given to the cochlea. And we came to a compromise that we should preserve our cochlea from a 4-gray radiation. Then there were some over-enthusiastic groups which tried to preserve even from the less than 3-gray. And overall, we are finding now that if you preserve your cochlea from the 3-gray radiation with whatever the SRS platform you are using, your chances of long-term hearing preservation are pretty high. All these are Coos grade 1 vestibular schwannomas, but they are inherently different. Your tumor is extending to deep into the internal auditory canal, then your chances of losing the hearing are pretty high. This vestibular schwannoma cannot be compared to the type D or the type E Ohata classification because they are extending towards the extrameatal component. And if you have some CSF space between the lateral extension of the tumor and the basal turn of cochlea, your chances of preserving the hearing are much higher than this one. I wouldn't give any option to this patient, any assurance of the hearing preservation to a type A, but definitely with a confidence I can give it to a type D or type E when I am treating with this gamma knife. And you need to do a hearing subclassification. A young patient less than 60 years of age with a grade 1 hearing loss, that makes your best candidate for the hearing preservation if you find nearly 3 millimeter gap from the lateral extension of the tumor. Now you can evaluate your healthy cochlea versus a sick cochlea. This is a signature statement which can tell you this patient is going to preserve the hearing or not. If you're on CIS imaging, high intensity, high weighted T2 image, you can find a hypointensity in the cochlea. That means this cochlea is a sick cochlea. Compare it to the opposite side, and this patient is definitely going to lose the hearing whether you treat or not treat. That's a prognostic marker that you can find in these patients. Nearly 40% of these patients who have a remnant, they show a growth, and in the next 10 to 20 years, they are going to need some or the other kind of the treatment. You treat them early, so whatever the cranial nerve function you have preserved, that's going to stay with the SRS rather than waiting and then irradiating when the functional status of those nerves are actually at a toss. So to conclude, observation is an option restricted to the small, asymptomatic, not growing vestibular schwannomas, especially in elderly patients with the significant comorbidities. Gamma knife is a valid option compared to the observation in the Coos grade, and this is the option of choice for the Coos grade 2 and the 3, rather than just observation. So these days people come after taking 2 or 3 opinions and having multiple questions in their mind. I just send them this PDF. This is a Delphi analysis and it answers their each and every question. This is a detailed analysis. I read it myself, I give it to them. They do not question anything more because we are dealing them in an environment of uncertainty. But if you are choosing an observation, you need to follow a strict protocol. That means for the next 5 years, you need a radiological and an audiological assessment with a comparative evaluation. This has a level 3 evidence, and the compliance is a big issue because nearly 50% of these patients are going to shift to either surgery or stereotactic radiosurgery in the next 5 to 10 years. So if it is in my head, that's a question which patients used to put to me. They usually do to you also. If I am less than 60 years of age, I have a gap in the lateral extension of the tumor. I can preserve the cochlea from less than 3 gray. and there is absence of tinnitus, I can give them an option. Yes, SRS would be one thing which you can have with a good long-term hearing preservation and the tumor control in the range of 92% in 1 year, 81% in 2 years, and staying stable after that 5 years. And whenever you try to treat these, your machine should be robust so that you can irradiate the cochlea without you can irradiate the tumor without injuring the cochlea, and that kind of a sharp dose fallout can be achieved with gamma knife. With other SRS machine, you can irradiate the tumor, but the cochlear sparing becomes very difficult. So this study which just Professor Nair gave me today, the overall hearing preservation is 60% in 7 years follow-up, whatever the SRS platform you are using, but facial and trigeminal neuropathy are much higher with the LANEC SRS. Radiation-induced neoplasia is a complication mostly in the patients with the neurofibromatosis. In an sporadic vestibular schwannoma, this is not different from the general population. And while we are discussing all this hearing preservation, the patient is least concerned about it. The quality of life study shows that their concerns are vertigo, tinnitus, and headache. Their other ear is working, and they do not have any concern with the hearing loss in the long term. Just on a lighter side, Khushwant Singh once told that to all my old friends who still want to hear something and putting the hearing aid, I do not know what do they want to hear, what they have not heard in their whole life. Thank you so much.
Thank you so much. You had excellently gone through the various nuances involved in this complicated topic. Thank you so much. With this, may I call upon the next speaker, Management of Medulloblastoma by Dr. Shyama Prema Sudha.
For inviting me for this talk. So as we know, medulloblastoma is the most common primary malignant brain tumor in children. Now there are 3 distinct age groups which have a very different biology and prognosis and treatment, and I'll be dealing in the interest of time with the most common age group, which is 3 to 16 years of age. So diagnostic evaluation basically consists of an MRI brain and spine and CSF cytology. We have to wait for at least 2 to 4 weeks if it is not done post-operatively within 48 to 72 hours of surgery. Similarly, CSF cytology should be an LP. It should not be from the port site. And if it is not possible to do it pre-operatively, we have to wait for at least 48 to 72 hours after surgery. The other investigations are basically done in order to look at the assessment for adjuvant treatment. We get an endocrine evaluation, an ophthalmic evaluation, a growth and IQ monitoring, and audiogram done for all the patients. So we still follow the Chang system for the staging of medulloblastoma. The difference is that the extent of tumor is no longer of relevance, but however, the degree of metastasis is still of prognostic significance and is used in many of the risk stratification trials. Now there has been a paradigm shift in the WHO classification of medulloblastoma. Medulloblastoma is no longer only histologically defined. It is now molecularly defined. So basically we have 4 molecular groups. We have the Wnt activated tumors, we have the SHH activated tumors, which can be TP53 mutant and wild type, and we have the non-Wnt, non-SHH tumors, which is a group 3 and group 4 tumors. Now why they are so called is because a classic driver mutation has been found in the Wnt activated tumors and in the SHH activated tumors, while it is not clear in the group 3 and group 4 tumors. So what did we know? So we knew that classic was basically a standard risk tumor, while large cell anaplastic behaved aggressively. However, in the presence of these driver mutation, they acquire a different biology altogether. For example, classic in a Wnt activated tumor is no longer standard risk. It is a low risk tumor. Similarly, large cell anaplastic in a Wnt activated tumor is no longer aggressive tumor. It behaves more like a standard risk tumor. So how do we identify the molecular groups? The simplest method is immunohistochemistry. So basically we have beta-catenin, which identifies a Wnt activated tumor, and we have GAB and YAP, which actually identifies the SHH tumor. So if the tumor is beta-catenin negative and YAP and GAB negative, then we say that it's a non-Wnt, non-SHH tumor, or a group 3 or a group 4 tumor. Further molecular characterization is possible only by molecular typing. This includes various studies like FISH in order to identify amplifications or deletions, the whole genome sequencing in order to identify mutations, and you have methylation arrays in order to identify the various subgroups in these 4 groups. Now coming to the treatment of medulloblastoma, so there are essentially 2 components. One is to elevate the raised intracranial tension because most of them present with a medical emergency, and next you have treatment which is actually directed to the primary tumor. Now, treatment directed to the primary tumor consists of surgery, which is maximal safe resection, with the aim of getting a residue less than 1.5 centimeters squared. So we have to remember that it's 1.5 centimeters squared and not cube, and not 1.5 into 1.5 centimeters squared. So what if the patient comes with a residue greater than 1.5 centimeters squared? The prognostic significance of a residue greater than 1.5 centimeters squared is less relevant in the molecular era. In fact, the presence of R+ status alone does not confer worse prognosis, and hence we send the patient for a repeat surgery if only a biopsy has been performed and safe resection is not possible. Now coming to the risk stratification of medulloblastoma. In the pre-molecular era, the risk stratification was very simple. We just had 2 risk groups. One was the average or the standard risk group, and the next was a high risk group. And this was actually based only on 3 factors, that is a residual disease, the modified Chang staging, and histology. But in the molecular era, it has become quite complex. I'll try to keep it as simple as possible. There are various actually risk stratification protocols. You have the Children's Oncology Group from America, you have the COP-PNET from Europe, you have the HIT from Germany. Basically what they have identified now is that there are 4 molecular risk groups, not 2. So you have a low risk, you have a standard risk, you have high risk, and you have very high risk. And this is based on the 5-year survival. So what makes it low risk? So if you have a classic in a low risk, in a Wnt activated pathway, it becomes low risk. Similarly, the presence of a chromosome 11 loss in M0 in a group 4 tumor makes it low risk. So what makes it very high risk? The presence of TP53 mutation in an SHH activated tumor and the presence of metastasis in a group 3 tumor makes it high risk, very high risk. What makes it high risk is the presence of MYC amplification in SHH group 3 and group 4 tumors, the presence of NMYC amplification in SHH tumors, and the presence of large cell anaplasia or metastasis in SHH group 3 and group 4 tumors. We have to remember that large cell anaplasia in a Wnt activated tumor in a child is still a standard risk, and it becomes high risk in a Wnt activated tumor only in post-pubertal children and adults. Now, this is a pathology specimen of a 9-year-old child with medulloblastoma. So there was cell-to-cell wrapping, and there was beta-catenin was positive. So the diagnosis was large cell anaplastic medulloblastoma, Wnt-activated tumor. Now, this is very uncommon in order to get a large cell anaplastic tumor in a Wnt-activated pathway tumor. So we did the mutation studies. We got mutation in exon 3 of catenin B1 and monosomy of chromosome 6, confirming that it is indeed a Wnt activated tumor, and we have treated the patient as standard risk and not as high risk. So basically, the treatment is based on risk strata. The advantage in Western countries is that most of the children actually they enter some part of a clinical trial. However, we do not have that luxury. Basically, what we do is we tend to treat them based on some standard protocol. Like we tend to treat low risk and standard risk in a similar fashion based on the ACNS 0331 protocol or the Children's Oncology Group protocol. High risk and very high risk, there is no standard treatment. What we follow is the ACNS 033 protocol. Now coming to the treatment of low risk and average risk medulloblastoma. So basically it is a reduced dose craniospinal radiation with boost to the tumor bed. By reduced dose we mean 23.5 gray to the craniospinal axis and boost the tumor bed up to 54 gray. We follow it up with adjuvant chemotherapy with either the PACA-A or PACA-B regimen into 6 cycles. We do not give concurrent chemotherapy during radiation because it is of limited value and only adds to the neurological toxicity. Now, we do not increase the dose of cyclophosphamide in Wnt-activated tumors because it is still experimental, and we have not reduced the dose of craniospinal radiation to 18 gray because it is still experimental. Now, treatment of high risk and very high risk medulloblastoma, we follow the ACNS 033 protocol, which consists of standard dose craniospinal radiation, which is 36 gray with a boost to the posterior fossa of 55.8 gray, and we give concurrent chemotherapy with vincristine or carboplatin in group 3 and adjuvant chemotherapy based on the ACNS 0332 protocol. Dose intensification protocols are tried only as a part of a clinical trial. Definitely, there is an advantage of protons over photons. The dose to the viscera is much less. However, it's very expensive and limited availability limits the use. We use photons. So there are complications of craniospinal irradiation. We can have neurocognitive dysfunction, including decreased IQ, infertility, and endocrine dysfunction, and second malignancy. In our JIPMER cohort, we had 2 cases of hypothyroidism, 1 case of uterine hypoplasia, 4 cases of delayed menarche, and 1 grade 1 meningioma. So what do we expect from a neurosurgeon? So priority is safe resection. Rather than attempting to get it less than 1.5 centimeters squared, early referral, because one of the most important prognostic factor is starting radiation beyond 6 weeks, which confers a bad prognosis. MRI brain and spine should be done within 40 to 72 hours, otherwise wait for at least 2 to 4 weeks. Similarly, CSF cytology should be LP and not from a port site, and wait for 2 to 4 weeks after surgery, and ideally refer the patient after complete molecular typing so that we do not waste further time in starting the adjuvant treatment. I thank you for your kind listening.
Thank you, Dr. Shyama. We will take questions at the end of the session if there is time. Thank you for showing us the risk stratification, and above all for the last few slides educating us as to what is expected from us. Our next speaker is Dr.
We have a small change in the program. We're having a small memorial for one of our residents who passed away a few years ago. We'll call you back after the 2 sessions. Thank you very much. Thank you very much. Thank you very much, Dr. Shyama, for that very brilliant exposition of medulloblastomas, both from a neurosurgeon and oncologist perspective. We have a small change in our program. A very precious member of our Sri Chitra family, Dr. Gulzar Gupta, left us for his heavenly abode in 2016. So we are having a small memorial reminiscences shared by his teachers and batchmates. For that, to begin the session, I would invite Professor Ishwar and a few of his teachers and batchmates would also be speaking and sharing some wonderful memories of Gulzar with us.
Good morning to you all. It's a solemn moment in our otherwise jovial, genial meeting that we have had in the last 3 days. This is about a gentleman who walked into our hospital in 2004 as a naive resident from Ludhiana, Dr. Gulzar Gupta. And he was a very soft-spoken person, quite focused in his work, and completed his course without any fanfare. Probably, I don't think I have heard Professor Suresh Nair kind of chiding him on anything, because he was such a nice person to be around with. Unfortunately, a few years ago, he called one of my colleagues, Dr. Jayanand Sudhir, and asked him whether you have gamma knife in your hospital. The reason why he asked this question was he was diagnosed as having a CP angle enhancing lesion, which was believed to be a schwannoma. Unfortunately for us and for him, it turned out to be an aneurysm which was missed, and he died of subarachnoid hemorrhage subsequently. I request all of us to observe a minute of silence in honor of our departed friend and gentleman. Dr. Gulzar Gupta. Thank you very much. I invite Professor Suresh Nair, who was the HOD at that time, to reminisce about Dr. Gulzar.
Good morning. I think Ishwar summarized about Gulzar. Say he was our resident. He passed out in 2006. We had two, Amitabh Gupta and Gulzar Gupta, and two Agarwals, Rajiv Agarwal and Nilesh Agarwal. One of the best batch we ever had. And Gulzar, as Ishwar told, was such a humble fellow. Whenever I used to ask a question, he used to take 2 steps behind, thinking that I am going to hit him. Such a gentle soul. Correctly, Ishwar told he had bleeding from, I have never seen an ICA aneurysm. This Gulzar had an ICA aneurysm which bled. And obviously some CP angle blood was there. People thought it is a cystic vestibular schwannoma which is prone for bleeding. So that is how they contacted me also. Ultimately, he was having headache all the time, abrupt onset of headache. Cystic vestibular schwannoma usually won't have that, even after bleed, they won't have headache. But he was, this is fighter aircraft, very unusual in Trivandrum. And ultimately, he had the rebleed, he was rushed to PGI, and he was on ventilator for more than 2 weeks, and ultimately he succumbed. 2018, while I was the president of Neurological Society of India, I had an opportunity to go to Ludhiana for a skull-based meeting. And that time I visited his house, met his wife, children, and what a loving soul he was. And his memory will always be with us. And I hope every year we should have some small program in his honor. Thanks, Ishwar, for giving me this opportunity.
Professor Ravi Mohan Rao is here. Please come, sir, to share your thoughts on Dr. Gulzar.
As Professor Ishwar and Professor Suresh Nair said, Gulzar was a very thorough gentleman, and his memory is still very fresh in my mind. And he was very humble, very soft-spoken, and always curious, wanting to learn as much as possible during his stay in Sri Chitra. The big irony is, he was in an institute which is renowned for cerebrovascular surgery. He was a well-trained neurosurgeon himself. He was a practicing neurosurgeon, probably clipping aneurysms. And he had an aneurysm which was not diagnosed until it was too late. So such is destiny. His batch is one of the best batches I have seen too. So it's very sad that we have to remember Gulzar in this way. May his soul rest in peace.
Now it is the turn of Dr. Matthew Abram, former HOD of our department, to share his thoughts on Gulzar.
Morning, everybody. When I think of Gulzar, I feel he was one of the best residents, best softest-handed residents that you have had. I think he is perhaps the only person I repeatedly said you should come as a postdoctoral fellow and ultimately become our faculty. He had a very high level of patient concern that I remember. And very few I have seen such soft hands as we transform from general surgery to neurosurgery, we need some form of hand softening. This Gulzar had it intrinsically. And I had the fortune of meeting him maybe, I think 2 years before he expired in Ludhiana when I went for a meeting. Such a lovely person, the same attitude after becoming a consultant. And my son had some vomiting, and Gulsar immediately brought an IV line, and in the hotel we gave him IV fluids and all these things. So sorry to hear. There is one important story we have, one important message we have to understand from what happened to Gulsar. He was a neurosurgeon who was clipping aneurysms, as Damodar Rout sir said. But somehow he could not diagnose his own CP angle or an ICA aneurysm. So I feel that if you're having a problem which you yourself may be dealing, it's better to get a consensus opinion from around. You may have deep intrinsic biases when you come to managing yourself. Partially so when it's your relative, and maybe even when it's your friend. So I think we should all remember. And another message I want to tell you, get an MRI at least once in 5 years for yourself. Rest in peace, Gulsar, one of our best residents and one of the best, sweetest individuals we have come across.
Thank you, Matthew. If there was one man who was a shadow of Dr. Gulsar from his batch, it was Dr. Amitabh Gupta, currently practicing in the National Capital Region. Over to you, Amitabh.
Good morning, everyone. Good morning, everyone. I think it's not my pleasure to be here speaking on my dear old friend Gulzar. He was not only my batchmate, he was a colleague, he was a family man, he was a friend, he was a lot. There are words very less to sum up all of that in very few minutes. This feeling which I got when I got the call from one of my colleague that something has happened. So I just rushed to PGI, and that was a time when I got to know that it was something that it was unsalvageable. As a neurosurgeon, you can just imagine the frustration, the difficulty, and more so when the family is repeatedly asking me what is the next step or what is the chances. Unfortunately, I could not offer them any kind of hope in spite of knowing that it is inevitable that things are going in a wrong way. But to say anything further, I would say that the time we spent together in Chitra, it was like a family. I will say Chitra itself is a family, but yes, there were a lot of comforts together we shared. I'll just take this short opportunity to call my batchmates Rajiv Agrawal and Nilesh Agrawal too, because we complete ourselves together. So I would say that it all started from 2004, as Professor Nair had summed it up very clearly, that 2 Guptas and 2 Agrawal entered an institute, and it was from there that we started our journey. And from there we began. He was very jovial. Whenever he had time, he spent with his family. He had interest in traveling. He has interest in gardening. He loved greenery, and probably that is the reason that he was in Trivandrum. He, after completing, was very clear that he is going back to Ludhiana. He joined a medical college. He joined as an assistant professor. He reached up to associate professor, and he had a very bright future. There's no doubt that if he would have been there, he would have been sitting here as a professor or probably a HOD of that particular college, that is DMC Ludhiana. And to talk about his practice, I think he was very clear and very clean. So there was no mincing of words when it comes to profession, and there was no way that he is going to neglect his family. So I would like to suggest even my young neurosurgeon friends that please do take care of your family whenever you have time. Unfortunately, the 2 girls, one is Nimisha Gupta, elder daughter, and she is now in medical college first year, Amritsar. I'll just rush through. This is the slide of our old Chitra days, whole of the batch there. This is some of the good times we shared, me and Gulzar. This is with Komal. Again, Professor Bhattacharya, Jayanand. This is one of the conferences we attended together. Now, this is the whole family. On the far right, you can see his elder brother Shiv, their family. You can see on the last, it is her wife, Shikha Gulzar Gupta's wife, and she is doing dermatology. These are the two daughters on the right. She is Nimisha. She is doing first year MBBS in Amritsar. And in the middle is Chetna Gupta. She is in 10th standard. So he was absolutely a family man to go with. And I think nobody can fill the void in a family more than what we have in the professional world. But yes, I believe that wherever he is resting in peace. I would now just like to give the mic to Nilesh and Agrawal, Nilesh and Rajiv to just share a few words.
It's difficult to speak on this. Gulzar was a true friend. Even if you don't talk to him for 15 days or 20 days, if you go to him with some problem, he will always have a solution. I remember those days, morning 6:30 to 8, it was a bashing time. We used to get a good bashing for Professor Suresh Nair. And the only person was Gulzar, who was like, oh, chill man, forget everything, it's just 3 years to go. That was his attitude towards life. As Amitabh said, he was a real family man and friend. The only thing I can say is, he should have not left us so early. Thank you.
Good morning. As a friend, as a philosopher, I will not say something. I will read a couple of couplets. काम करो ऐसा कि पहचान बन जाए, हर कदम ऐसा चलो कि निशान बन जाए. यहाँ जिंदगी तो सभी काट लेते हैं, जिंदगी जियो ऐसे कि मिसाल बन जाए. For Gulzar, who was not only a soft-hearted and very kind person, these are the two lines by Rahat Indori. सूरज हूँ जिंदगी की रमक छोड़ जाऊँगा, मैं डूब भी गया तो शफक छोड़ जाऊँगा. R.I.P. Gulzar, we miss you.
His favorite dialogue at the end of, as just Rajiv told, was, "Appa sab kar lenge." So he was a true Punjabi. He enjoyed his life. He enjoyed the course. And most of all, he enjoyed the time he spent. He died at a young age of 40, but I think he has many more years and memories to go down the lane. Thank you.
Thank you, Amitabh, Rajiv, and Nilesh. We continue with our academic presentations now. And we also wish to announce that along with the Dr. Damodar Rout Oration, the young neurosurgeons' presentations will be named after Dr. Gulzar Gupta in future. And we are also planning to introduce a fellowship for the final year residents in the name of Dr. Gulzar Gupta to attend conferences abroad and probably fund research initiatives from the residents. Thank you very much.
May I once again invite to continue the academic sessions Professor Vivek Joseph and Professor Venu Gopal.
So I invite Dr. Anand Balasubramaniam, who will tell us about relevant glioma markers.
Good morning. We change gears to something much simpler, which is more didactic but very practical. This is the WHO 2021 classification, only gliomas we are going to talk about. As you know, we normally hear it from pathologists, and they are always excited about a lot of new markers which have come. And now we have glioma panel, and most of us, after operating, we ask the pathologist and they put on a glioma panel, and then we get confused. There is monetary implication, there is prognostic implication, and we don't know which marker to ask for and how to go about it. So from a clinician's perspective, This is to give you a short, kind of oversimplified version, but which is more practical. So the new WHO classification, as you can see here, the adult type diffuse gliomas is what we are going to talk about. We are not talking about the pediatric type diffuse, low grade or high grade, or the circumscribed astrocytomas. They are totally different altogether. So the adult type diffuse gliomas, originally this was 2016 classification, as you can see. There were multiple, and they were all divided into IDH wild type or IDH mutant. So this has changed completely, and now there are only 3 types for you to remember. So you have the IDH mutant astro, and you have the IDH mutant oligo. There is no more oligo astro, that has gone away. And then you have the IDH wild type glioblastoma. So these 3 ones are simply defined with certain diagnostic markers, and most of the markers that are talked about newly are prognostic markers. So I'll try to tell you when it is required to do the extra markers other than, say, IDH and the basic diagnostic markers. So in this diagram, if you see, this is the old classification. So old classification had the astrocytoma, oligo, glioblastoma on top, and then was divided into wild type or mutant type. Now it's much simplified. We start with the IDH actually. Is it mutant or wild type? If it is mutant, then you go down the ATRX P53 pathway, which becomes the diffuse astrocytoma, which is IDH mutant. If it is grade 4, it's no more called secondary glioblastoma, it's called grade 4 glioma. In the IDH mutant with 1p19q co-deletion, you have the oligodendroglioma, which can be anaplastic. So you see the grades are coming below the diagnosis, it's not on top. The IDH wild type is straight away grade 4 glioblastoma. There is no grade 2 or grade 3 in that group, and then we'll come to the markers shortly. So the first, this is the IDH mutant, the first of the top, the IDH mutant astrocytoma. This is a good prognosis group. There are 3 grades in this. So histomorphology is still important. Don't forget this. I think this is the main take-home message. Don't forget histomorphology. Your classification of nuclear pleomorphism, microvascular proliferation, necrosis is very important, mitotic activity. So if it is grade 2 according to that, it's grade 2. Grade 3 according to that, it's grade 3. Grade 4 according to that, it's grade 4. So if it is grade 2 and you are worried that whether you are actually treating a grade 2, you don't want to miss a grade 4, which looks like grade 2, only then the molecular marker for prognosis, CDKN2A, comes in. If that is positive, then it becomes directly grade 4. So if it is already grade 4, you don't have to do this marker. So this marker is superfluous, and please don't ask for it up front. So it is IDH, that's all that is required. And the diagnostic marker for astrocytoma is the ATRX loss and P53. This is very central. You have to remember here, if ATRX and P53 are mutant or lost, the 1p19q is reciprocally not deleted. If this is retained and it looks like an oligo, 1p19q is usually co-deleted. So it can be used as surrogate, so you need not even ask for 1p19q. So only 3 markers you have to remember for diagnostic. IDH, which is overarching, ATRX P53, which is diagnostic. Now I'll spend a little while on T2 flare mismatch, which is also very important in radiology for you to pick up, and then the prognostic factors, which is age and extent of resection. So what you have to remember is, if you have already age, a bad prognostic factor, and extent of resection is not complete, you are anyway going to treat this as a high-risk patient. No point in trying to do a CDKN2A marker, even if it is grade 2 or grade 3. So be practical and don't be too textbookish in what you want to define, unless you are doing an academic study or a research protocol. So this is the T2 flare mismatch, which is highly specific for IDH mutant diffuse astrocytoma, irrespective of the enhancement. So this TCGA study has given very clearly, as you can see on the right side, clear T2 flare mismatch, and you have a ring sign. If this ring sign is present, it's even more specific. So these are very highly characteristic of IDH mutant astrocytomas. If you have this information before, you know these tumors are good prognosis, they are resectable, and if you leave behind residue, it's going to be a high-risk case. So you can do all that you want to resect this tumor completely. So these are the cases in which you have to put all your effort and do. So it's good to have this knowledge beforehand. If there is no T2 flare mismatch, it can be any of the three. The first one turned out to be IDH diffuse astrocytoma mutant. Second turned out to be a oligo IDH mutant. And the third one turned out to be IDH wild type GBM. So when you don't have a T2 flare mismatch, you are lost. You don't know what to do. You go by merit of the tumor and merit of the case. I'm going to give you some clinical scenarios and tell you what the pathologist report was and what markers they have suggested and whether it is right or wrong in this situation. So this is an insular glioma in a young lady whom we had resected, and there was a residual tumor. So how do we manage this residual tumor? She was young. There is a residual tumor. You can see that it is on the upper part of the insula, and we could not resect it because she was getting speech disturbance. So this actually turned out to be IDH positive astrocytoma mutant, and 1p19q was not co-deleted. The ATRX, as I said, are surrogate. They are mutually exclusive. ATRX was lost. So in this case, if this is truly grade 2, we can wait and watch. If it is not grade 2, we have to treat it upfront. So this is where CDKN2A comes important. So we did CDKN2A analysis for this, and it turned out to be not co-deleted. So we are observing this patient, and this is how we have to proceed for CDKN2A. If it was already grade 3 or grade 4, we would have subjected her anyway to radiation and chemotherapy. We need not have done a CDKN2A. Now this is another patient who had undergone surgery, and we had to do a redo because there was a recurrence. This turned out to be a IDH mutant astrocytoma, and you can see here that there is ATRX loss, and the tumor is already having endothelial vascular proliferation. So this is already grade 4. In this grade 4 IDH mutant, it becomes IDH mutant grade 4 glioma. You need not do any more of CDKN2A. They have suggested it in the pathology, but it is superfluous because we already have grade 4 based on the histomorphology. Now we come to the second group, that is IDH mutant oligo. So here, if you have already done ATRX P53, it looks like an oligo, and ATRX P53 are not mutated. You need not even ask for 1p19q. If you want to be sure, if you are doing a study, then do it. It is expensive. FISH is not easily available in all centers. So ATRX P53 is a good surrogate marker. So prognostic factors are age and extent of resection. We stick to that. Now in the wild type, this is the most important. I'll spend a little while here. So if you already have IDH wild type and it is grade 4, you need not do these three markers, TERT, +7, -10 or EGFR. If it is IDH wild type and if it is grade 2 or 3, then these markers are important. Because there is no grade 2 or grade 3 IDH wild type, they become NOS, not otherwise specified, because we don't know what is the defining mutation in these patients. So if it looks like a GBM, it is IDH wild type, confirmed with sequencing, you are treating a GBM, you don't need to do any of these markers. So this is again a patient in which we did a stereotactic biopsy. We did find out that there is IDH negative. We have done a sequencing also. You can see that the pathologist has asked for 1p19q, and then the confusion has started for IDH sequencing, and they have marked about NGMT methylation. And they have asked for CDKN2A and TERT, none of which was required, because there is already IDH wild type with sequencing, and it is grade 4. All you had to do is only do the IDH sequencing and MGMT methylation. MGMT methylation is important to know, especially in elderly, whether you want to do hyperfractionated RT or you want to give temozolomide. In other situations, MGMT is not required, and please don't ask for MGMT in all gliomas. Elderly, compromised KPS, you want to hyperfractionate or give only temozolomide, MGMT is important. I'll quickly finish with these two. The diffuse midline glioma is no more called DIPG. It is H3K27. Don't ask for IDH here. These are the classical DIPGs. They are characterized by H3K27 mutation, the only marker you require. Same thing for gliomatosis cerebri. No more gliomatosis cerebri. It is called the diffuse hemispheric glioma, the pediatric type. IDH has again no role here, and the marker is H3G34. So to conclude, I will say grading, the new grading, prognostic and diagnostic informations are there. Most important is IDH, ATRX, P53. The extra markers go for only if it is looking like a low grade and you have to prognosticate further. And MGMT only in elderly GBMs. Thank you for your attention.
Thank you, sir. As you rightly pointed out, molecular and biomarkers will be the future of glioma surgery. So with this, I invite the next speaker, Insular Glioma Resection, Art and Science, Dr. Kuntal Kanti Das.
அந்த சைடு கனெக்ட் செய்ய இது இந்த கேபிள் நோக்கணும் லாஸ்ட் டைம் கூட கனெக்ட் டு தட் சைடு இப்போ நோக்க சொல்ல அந்த சைடு
Hello. Due to some technical hitch, we will have the next speaker, Professor Gopala Krishnan, MS, who is going to tell us about Sealed with a Kiss, Closure Matters. Okay, we will continue with the current speaker. Yeah. We'll continue with the current speaker, Dr. Kuntal Kanti Das, Insular Glioma Resection.
Good morning, respected chairpersons, and good morning, everyone. I'm going to talk to you about insular glioma resection. Insular glioma resection is considered to be one of the challenging tasks, mainly because of the fact that the chances of neurological deficits are rather high, and more often than not, we end up resecting the tumor suboptimally. But due to the pioneering work of several neurosurgeons, including Professor Yasar Gill and Professor Dufo, we have come to a stage now where these tumors can be resected a large extent of resection can be obtained with acceptable complications. And one more thing has happened recently is that the initial reliance on purely anatomy and topography based resections have given away to more functional based resections. But in my opinion, and as I'm going to show to you, that a middle path combining both is what is probably most appropriate. Now, before we go deeper, we need to understand the anatomy of this region. As you all know, the insula is located deep inside, and it is covered by the frontal, temporal, and parietal operculum, and it lies at the depth of the sylvian fissure. Therefore, in order to reach the insula, we need to either split the sylvian fissure, in which case we have to go through the vein, go through the arteries in order to reach the insula. And the second way is to resect the operculum, that is temporal, frontal, and parietal. And on the left side, particularly on the dominant side, this can harbor very important functions. Therefore, reaching the insula by whichever method you employ is difficulty number one. Secondly, we need to also understand that the concept that all patients with dominant insular gliomas will have functional operculum is probably not correct. This important study published recently by Palud et al. Has shown that on the right side, almost no patients of theirs had any function involving the temporal pole and the superior temporal gyrus, whereas the area of the pars orbitalis, that is on the frontal side, hardly contains any function, whereas as you go posteriorly in the area of the pars triangularis and the pars opercularis is where the function lies. Therefore, the take-home point from this slide is, if you need to make cortical incisions, you can safely make in the temporal pole, the superior temporal gyrus on the anterior part, pars orbitalis, and perhaps pars triangularis. But if you have to go further behind, you have to understand that the chances of complication would be high. Another important thing that you need to understand is the anatomy of MCA. As you see here, the MCA drapes the insula. Therefore, in order to reach the insula through a transsylvian route, you have to go through the arteries. Whereas if you're taking a transcortical route, as I'll show, you can work beneath the insula. Two important set of perforators you need to keep in your mind. The deep lenticulostriate perforators, as you see in this image, are located on the medial side. And earlier, we used to believe that the tumor of the insula would press these arteries medially, meaning that you can go on resecting the tumor until you have encountered the lenticulostriate artery. But the present understanding says that in around 20% of our patients, this artery may be engulfed. Therefore, it is probably not prudent to chase the artery and stop well before that. Another important thing that I would like to highlight is that the subcortical anatomy. You'll find it strange that even after resection of the insula, the patient actually doesn't develop deficit. The deficit is because of the subcortical white matter tracts. And three important tracts that need to be remembered are the superior longitudinal and the arcuate fasciculus, which is marked superiorly here. It comes at the deeper part of the superior periinsular sulcus. And the inferior fronto-occipital fasciculus, IFOP, it comes at the deeper part of the inferior periinsular sulcus. And the corticospinal tract is further deeper, and it comes on the posterior part of the insula. Therefore, when we are resecting these tumors on the deeper side, especially at the level of the periinsular sulci and the posterior insula, we have to remember that these tracts are there, and if you damage these, you are going to have complication. A couple of other points I want to mention here is, insular glioma, as it expands inside the insula, what it does is, it causes deepening of the periinsular sulci. Therefore, this can be utilized during surgery, as I'll show in the video. And as the tumor comes out of the insula, it arches around the depth of the periinsular sulci. So what is the significance? The significance is, as this tumor is coming out of the insula and going into the operculum, it pushes the long tracts that I've shown in the earlier slide medially. So you have extra few millimeters of safety margin with you because of this specific anatomical displacement of the tract. And another important new development has been this condition called exophytic insular glioma. Normally, with our anatomical understanding, we know that the insula is deeper to the middle cerebral artery. But if you see an image like this, where some part of the tumor is anterior to the middle cerebral artery, you should know that the tumor is exophytic. An exophytic tumor can be very well approached through the transsylvian route, unlike a tumor which is purely inside the insula, in which case probably a transcortical is a better option. The challenges can be further aggravated by the higher grade histology of the tumor. As we have shown, that such tumors will have increased chances of bleeding. They tend to destroy the sulcal planes, and they tend to involve the lenticulostriates more commonly, meaning that these tumors are more dangerous compared to the lower grade tumors. Then this challenge also increases if there is multifocality. There is a big debate as to which approach is better. My personal take is it depends on the extension of the tumor. If the tumor is confined to the insula, it is small, probably it can be approached through the transsylvian route. If the tumor is large, has involved the operculum, is causing epilepsy, then there is no point of going through the insula, and this is what we have published recently. So how I do it? As I said, I take the middle path. I still rely heavily on the surgical technique, the landmarks and topography, and as far as the adjuncts are concerned, I work in a setup where I don't have the full gadget of adjuncts, so I rely on triple motor mapping, which consists of transcranial MEP, cortical, subcortical mapping. I prefer the transcortical route, as I said, only in exophytic tumors and in tumors which are small and located inside the insula is where I'm going to take the transsylvian route. I routinely make cortical windows in the temporal pole, superatemporal gyrus, and pars orbitalis. Pars triangularis and posteriorly, I need to be more careful. I give a lot of importance to visualization of the peri-insular sulcus because for me, I think this is very key to resection of these tumors as completely as possible. And on the medial side, I tend to rely on the color change of the basal ganglia and some venous bleeding. I never try to see the artery. I stop at the point where there is some venous bleeding. So to give you an example, I'm going to show you two cases. This is a patient of left insular glioma with seizures. Here we can see that there is a tumor in the insula involving all four zones, and the tumor is poorly outlined. The corticospinal tracts are displaced posteriorly. After craniotomy, we begin with mapping of the cortex in order to find out in a functional area. And we also use ultrasound. Here we begin with temporal polectomy. As you remove the temporal pole, you can see the posterior inferior part of the tumor. You start decompressing this area. Further removal of the anterior part of superatemporal gyrus exposes the zone 2, the so-called posterior superior part. This patient was operated under AVIC conditions, so simultaneous monitoring can be done. Then suprasylvian window was created and tumor was decompressed. I would like you to see that I'm trying to visualize the peri-insular sulcus, as you can see here. For me, visualizing the sulcus is very important. This converts this tumor to a similar to convexity meningioma to an extent. And as you decompress the tumor, you tend to join the frontal and temporal windows beneath the middle cerebral artery. So this is the beauty of transcortical approach. You do not handle the middle cerebral artery directly, you work beneath it. And intermittently, ultrasound application is necessary because low-grade gliomas can be very difficult to distinguish. And I'm resecting the medial part of the tumor here. Here, one has to be very careful. You cannot visualize the artery. You have to stop at a point where you encounter some amount of venous bleeding. That vein generally comes before the artery. And on the medial side, after you have confirmed that you have removed as much of tumor as possible, then you look at the basal ganglia appearance, the granular dotted appearance, and at this point, you generally stop. These are the cortical incisions that were made, and the tumor was maximally resected. Post-op scans show a satisfactory resection. A very small residue can be seen close to the internal capsule. The patient developed transient speech deficit, which recovered at day 3. Small amount of residual can be seen here. And this patient made a satisfactory recovery. The second patient is another patient with left insular glioma, but as you can see, compared to the previous patient, this patient has some amount of tumor marked with yellow, which is going in front of the middle cerebral artery. Therefore, as I showed you in the beginning, this was a case of insular glioma with exophytic extension into the sylvian fissure. Such patients can be taken up for transsylvian approach because the sylvian fissure is already split by this exophytic part of the tumor. Otherwise, it will not be easy. Similarly, we start with cortical mapping and we try to find some functional areas. Here, as you can see that there is tumor right in front of you. So you have to resect the tumor initially, and after you have resected this exophytic part, you see the middle cerebral artery. This is very important. So the tumor was exophytic. Now, the rest of the step is similar to a transsylvian approach. You visualize the peri-insular sulcus. Here, since you are transsylvian, so I'm working through the middle cerebral arteries, the different branches. So that is why people say that transsylvian approach has higher risk of ischemic complications because you need to work through these arteries. Here I'm cutting the short insular perforators. You need to understand that the insula is perfused by short insular perforators. So if you cut these vessels, you not only devascularize the insula, but you also add some amount of mobility to the middle cerebral artery. So this artery can be mobilized and the tumor can be resected. As I said, for me, it is very important to look around the tumor, the peri-insular sulci, and at the depth, utilize your visual cues as well as subcortical mapping to ensure that the tumor has been completely resected. The postoperative scan shows satisfactory resection. Sometimes posterior part of the insula may have some residual and it may be difficult to remove it completely. So complications do occur after tumor resection, but as you see this slide, most of the complications, they tend to improve with time. And one particular point where I would like to draw your attention is the severe motor complications that are present immediately after surgery. They are generally because of lenticular striate artery damage and they don't improve. But the language deficits, for some interesting reason, probably because of redundancy of the pathway, they tend to improve with time. In my own personal experience, which I published recently, I found that all the permanent complications are motor, and the language function tends to improve with time. Therefore, to conclude, I think most often than not, you would be able to resect insular gliomas maximally with minimal complication if you rely on a middle path technique, that is a lot of reliance on topographic anatomy and utilizing the bare minimum monitoring that you have, that is triple monitoring. Surgical technique is irreplaceable. Whatever adjunct you have, at the end of the day, it has to be the technique. Transcortical approach is more versatile and one should be well versed with this. Language function has excellent recovery potential and you should not be afraid if the patient has some language deficit immediately after surgery. And for me, you should give every effort of yours to preservation of lenticular striate artery because the damage that arises because of this can lead to poor quality of life. Thank you.
Thank you. May I call upon Professor Gopalakrishnan MS for the next talk.
I hope I have gathered your attention with a provocative title. It's a privilege to come here. Thank you, Ishwar. Thank you, everyone. Yeah. So every surgery has to end with a closure. And I don't know what Cushing had in mind when he said, tell them I closed the galea. Maybe he thought about the possibilities of a very meticulous surgery having an unexpected back rank checkmate if you have a problem with the closure. So that's what I'm going to talk about, an upgrade for the closure. So in my opinion, the scalp closures and dressings are a mess. They are bulky, they have leaky closures, leaky drains. Most often it is painful to remove if you use elastoplast. And there is adhesive residues, need for compression bandage, superficial infections, and wound dehiscence and lots of problems. So you must agree with me that closure requires improvement. I don't know how many people are residents here. How many of you are residents here? I don't know. But it is applicable to both residents and super skilled surgeons here. So what I am suggesting is what is theoretically the best form of closure. It should have a high wound strength that is durable, lasts for weeks, and should not cause wound ischemia at the edges, either because of your gunny back closure or because of the pressure exerted by unnecessary number of staples put. There should be reduced inflammation. All wound heals with inflammation, but things that you put inside the wound also increases the inflammation, congestion, lumpiness, itchiness, and it should have some antibacterial property. I have seen, we would have all seen, and we would have also scrubbed patients' skin for hours together, or maybe 20, 30 minutes or 15 minutes of scrubbing. But we know that the bacteria die in the few minutes after scrubbing, and it doesn't really matter whether you scrub for many minutes because it is in the pores of the skin that the bacteria live and thrive. So then it comes to the ease of applying a suture. It should have good glideability and low friction. And obviously you should not have any reason to remove the stitches, should be absorbable, and should not have retained fibers, stitches, and nasty stitch abscesses. And since you are imaging the patient within 72 to 48 hours, surface staples can sometimes cause imaging artifacts. So the combo that I am suggesting is a PDS or polydiaxanone suture for galea, 3-0, continuous running. And why? Because it retains 25% of strength even after 6 weeks. And, but absorption is complete only after 6 months. It maintains integrity even in infected tissue. Now, why would you want to have integrity in infected tissue? For example, if you are doing an immediate titanium cranioplasty after a bone flap infection, you don't necessarily have to wait for 6 weeks. You can directly put a titanium and do a cranioplasty. There it is, has relevance. It should have less friction. It has less friction, but knotting is less secure. So that's step number 1. Step number 2 is polyglycapron, otherwise known as monocryl, famous as the trade name. Continuous running, undyed, subcuticular, otherwise called intradermal continuous sutures, quicker absorption, completely by hydrolysis, no inflammation. So, and it has very low friction, good gliding, excellent knotting. You could even use 4-0. And no extrusion chances as shown in the randomized controlled trials. And coming to, did anybody guess what the 4 stars were? Okay, so you should seal the incision with a 2-octyl cyanoacrylate glue over a mesh, which is a water-resistant, bacteria-proof, and vapor-permissible dressing. So this is commercially available as Ethibond, and it is available as Dermabond Preneo. But even if you don't have it, you can use a hernia mesh with a cyanoacrylate glue. So this is what I'm talking about, a completely transparent dressing which prevents any egress or ingress of bacteria and seals of the pores. So the advantages: clean, almost see-through incision. Patients can shower their head if they want immediately after surgery. No stitches to remove. Much less chances, almost 0 chances of oozing of blood, CSF in the immediate postoperative period. Possibly less chances of infection and wound dehiscence. So rather than the beauty of the closure, it's also about infection control, because we know that a CSF leak, a single CSF leak changes the equation. The glue seals off the bacteria permanently like an incise strip. It is moisture retaining occlusive dressing. Could reduce leak, but I thought it will never cause leak until the last case which leaked actually. So I'm not so confident any longer. The triclosan coating on the monofilament is antibacterial. So can you prove it? Yes, you can randomize and see, but the incidence or the, even if the effect size is huge, you will require literally thousands of patients to show a difference, maybe around 5,000. I don't see that happening. So this is the recipe. Cavalon spray after preparing the skin. Again, the idea is to seal off the pores of the skin to prevent the bacteria coming out, and then a tungsten needle, then put vancomycin over the bone flap. Some amount of research shows that there is reduced infection. Go ahead with polydioxanone, polyglycparum closure, and seal it with a glue. So that is what is. Earlier I used to just part the hair and cut off directly without any shaving. Don't shave the head of the patient. It causes more infection, and that's for residents. Of course, if you're so used to shaving the head, then you cannot get out of it. But don't shave the head. But in this particular closure, you need to have a clipping of 1.5 centimeters around the wound. So then polymer spray, that is a Cavalon spray. It is not permanent. That's not what I'm talking about. Then you'd use direct incision with a 0.5 micrometer tungsten needle, Colorado needle that is. So yeah, so that is, see how the Colorado needle impacts the skin at 90 degrees. It should be at 90 degrees so that it incises the skin without drag, without friction, without bleeding. And the cosmetic outcome is quite good. You have almost frictionless cutting. Right, I'll skip. So those are the steps. Whatever surgery you have done, whatever big surgery you have done, you put back the bone flap, put vancomycin, 2-layer closure with polydioxanone, polyglyperon, then exit site of the drain. If you choose to put a drain, glue it and glue the scalp, and that's what the final product is. So at the end of surgery, of course, you have a hair salon, wash the hair, see the dressing. It's almost transparent, and the blood has to be taken out. That's all you need to have. This is another example of a patient who has lost both his frontal lobes as well as his bone flap because of a Jallikattu incident, Bulgur. You don't necessarily have to have 3D printed titanium with very high cost to put here. You can actually pre-mold it in the OT using a skull and then sterilize and put it, and the cosmetic outcome is almost the same, and you cannot really distinguish between a real 3D printed skull and one that is done here. The contours are good because the frontal bone is almost the same for everybody as long as you don't use a Japanese skull. Oh my God, yeah. Yeah, so the contours are good, and then seal it off. Yeah, so this is how you seal it off. You see how beautiful the dressing is, and it seals off the bacteria. Keep a little bit of the glue for the pin side bleed and the pin side holes, and you don't need staples, you don't need to suture and get a prick. Again, wash it out. So the incision is almost invisible, and it's just not for the scalp. You can put it anywhere, even in the for a carpal tunnel, and then you can use the hand immediately and wash it. So, ladies and gentlemen, this is the new closure paradigm. If you're interested, it is based on evidence. There are multiple randomized control trials for each of the steps that I have shown. Yeah. Thank you. You have questions? Oh, we can't have questions, right? Thank you.
Thank you, Professor Gopalakrishnan, for sharing new thoughts with us. Our final speaker for this session is Dr. Ayyadurai, who will be telling us about endonasal technique for the pineal region.
It should be okay. It should come now. Let's give. Very good morning. I would like to begin saying thanks to the organizers for giving me the opportunity. So, pineal region is a challenging territory for even for an experienced neurosurgeons also because of the conglomeration of the veins and the neurovascular structures present there. This was developed by, from the beginning of 1910, refined, developed by multiple pioneer surgeons, and it's practiced mainly when the veins are anterior to the tumor. This approach was mainly described to the midline, minimally invasive, fully endoscope assisted approach, has steadily gained acceptance and reliability. So I'll just start with quoting this paper, like Peter Nakaji et al. They have analyzed the surgical freedom of endoscope assisted supracerebral infratentorial approach in 4 corridors, like midline, paramedian, lateral, and then extreme lateral. They called surgical freedom of a neurosurgeon is the ability to manipulate or maneuver the hands at the depth of the tumor area to maneuver the instruments is what called as surgical freedom. So they have analyzed this surgical freedom at the depth and then found out that the extreme lateral approach had the maximum amount of surgical freedom, and surgical freedom for anatomical target like pineal gland, splenium, ipsilateral superior colliculus. They have found the ipsilateral colliculus or the splenium area was found to be the better, it had the better surgical freedom. To the target, it revealed maximum freedom to the pineal region through the lateral approach, midline approach to the splenium, and the extreme lateral approach provided maximum freedom to the superior colliculus level. Though this was compared with the endoscopic and the microscopic parameters, it did not have too much of a difference. It was statistically not significant, and then very negligible difference was found. So this is how, like now I'm me sitting, the lower picture, it's me sitting like struggling with the microscope. I'm a star searched person. My hand won't reach to the depth, or like now handling the instrument at the depth with this posture, like it's going to be very difficult, and then like for a long time I cannot continue doing this. This is not an invention, but then like now I've improvised my experience with the intranasal 400 approach into this surgical area. This is how the assistants hold. There are two different assistants are there. They get used, like both of them are my residents, and then you just have to give them some time, and then in one case itself they get used to this. We can see the preoperative image on the top there, like no, that's the pineal region lesion. So the first access is always like now through the endoscope with a suction or with the dissector, just and go underneath the tentorium, inspect the surgical area, look for the veins, and try to get into the depth, and then release some CSF, the cerebellum sinks down. We can do the same way of dissection like what we do with the microsurgical approaches, but then here what we had to use is the monoshafted instruments. Like we may not have too much of freedom with the dual shaft instrument like the bayonet. So the tumor capsule is identified, same microsurgical principle we do it. Here the endoscope is kept at the level of the tentorium at the 10 o'clock. Maybe sometimes like it can be moved to the extreme lateral also. This is at the lateral part. The opening is only one side, exposing the transverse sinus and then little bit of a small suboccipital craniotomy. The dural opening is crescent shaped. The veins which lie laterally, like they don't cause too much of problem, and then smaller veins like cauterizing them and cutting them would not cause many major issues. Same way, always visualize and then do it, have some patience, and then like in the depth too, like the same way, your instrument goes in first and then the endoscope follows it. And at the depth, before we try to do anything, like the endoscope is brought into the view, and then make sure that like what we are doing. So the third ventricle roof is starting to come in to view. We can make out like the capsule is nicely being peeled off the way we do in the microsurgical resection. Only thing like as I said again and again, like the monosoft instruments will be the key trick here. That's on the brainstem, like we are peeling it off the brainstem there. We are dissecting off the lateral walls, and then we are starting to see the interthalamic adhesion there, and then yeah, that's towards the end. Like when we have a visualization, like we see the interthalamic adhesion, some tumor stuck to the interthalamic adhesion there. That's the phonesis, both foramen of Monroe and floor of the third ventricle. Like now here we see the roof of the third ventricle with the both the internal cerebral veins running there. This much of view, this beautiful view, we would not get it with the microscope. And this would be the opening, like this is towards the end, like after when we flush out to get the air out, that's all is the opening required. Same way I practice this for the microvascular decompression also, like sitting position, endoscope assisted. Similarly, though it is related to this because of this, the location I just wanted to show this, it makes it very easy, bloodless procedure and quicker to once if we start getting used to it. Similarly, like we had a trigeminal schwannoma presenting with the trigeminal neuralgia. We can see the first picture showing the tumor with the bony eminence, trigeminal eminence obstructing that, and then we can even still do drilling with the endoscope on it is possible to do it, and then this is, we are using the bone QSAR to further refine it. The fifth nerve is starting to come into appearance once if we start removing the tumor. At the end, the tumor had compression by the tumor, and the nerve had a compression by the tumor and by the superior cerebellar artery too. Here we have kept a Teflon patch between the SCA and the fifth nerve. And that's the opening we have done. So with this approach, for the pineal regional tumors, 17 cases, 6 were GTR, 5 were near total and subtotal were 6. These are the various pathologies. 25 trigeminal neuralgias, and then all the patients, in sitting position, they had 5 symptomatic pneumocephalus with headache, and that doesn't have to be done anything for that. And most of the patients, almost all the patients, they had minimal pneumocephalus. Air embolism, there was no air embolism, and then no significant neurological deficit except trigeminal numbness, and other deficits nil. So posterior location of the veins will be an contradiction basically for this approach, and then surgeon's comfort, if the surgeon is comfortable doing the 400 approach, it's the best. And the cardiac illness preventing the sitting position, we cannot do this. Extreme lateral extension of the tumor in the depth will be again a limitation. Consistency, hard consistency was the main reason why I had so many total excisions. And assistance comfort level also, but then it's not a major issue, by time goes, they get used to that. It's a versatile technique, efficient alternate to microscopic approach, no retractor surgery, no venous compromise, alleviate the need for the 3D view, appropriately selected cases. This is a very good approach to consider for. Thank you.
Thank you very much, Dr. Ayyadurai, for that nice demonstration and showing us the anatomy of that region through an endoscope. With that, we come to the end of this session. The organizers have indicated that we don't have time to take questions. If you have any questions, you can talk to the individual speakers directly who are still sitting here in this hall. Thank you.
Thank you, sir. May I now call upon the speakers of this previous session to come on stage and collect their certificates and mementos. Please, sir. Dr. Vernon Vello, Dr. Matthew Abraham, Dr. Manjul Tripathi, Dr. Shyama Prema Sudha, Dr. Anand Balasubramaniam, Dr. Kuntal Kantidas, Dr. Gopalakrishnan MS, and Dr. Ayyadurai. Thank you, sir. We will begin the next session. The theme of discussion for the next session is spine. May I invite the following chairpersons to take their seat on the dais. Dr. Kurian, Head of the Department, Jubilee Mission Hospital, Thrissur, and Dr. Nupur Pruthi, professor from the Department of Neurosurgery in NEMHANS.
Good morning all. So we start the session of spine. Dr. Damodar Rout is giving a talk on deformity correction. Stage is yours.
Thank you, Chairperson. Hello. Thank you, Chairperson. I shall be talking briefly about the spinal deformity and my early experience regarding it. Now, as we all know that spinal deformity is actually a broad spectrum of conditions, and the age ranges from the congenital lesion to in elderly patients, and depending upon the age, the causes can be varied. It can be congenital, it can be degenerative. The most important thing is that these conditions are often neglected, primarily because the initial symptom might only be a back pain of the patient, and the patient just keeps on taking oral analgesics, and he keeps on neglecting it. By the time the patient starts developing some neurological deficit. Now, the problem with this spinal deformity correction is it is one of the most taxing and one of the most complex spinal surgery, if not the most complex spinal surgery. However, unfortunately, less neurosurgeons are involved in the correction of deformity. So, as I just mentioned that the etiology of spinal deformities can be varied. The idiopathic is by far the most common. However, neuromuscular, degenerative, congenital and other also play an important role. I shall be briefly touching upon each of these pathologies. Adolescent idiopathic scoliosis is by far the most common pathology that usually a spinal surgeon encounters. It is more commonly seen in females, and right side it is more common. As the name suggests, we don't know why it happens. However, it is important to understand that these patients they usually present from the 12 to 16 years of age group, because primarily there is a growth spurt, and then the deformity manifests itself or actually shows the growth of the deformity. This is one of our patients who was a 16-year-old gentleman who had presented to us with progressively increasing deformity, and you can see the Scott film on the right side in which you can see the thoracolumbar scoliosis. One of the most common variety of deformity that we encounter as neurosurgeons are the neuromuscular variety, and this primarily occurs because there is weakness of the paraspinal muscles. The common causes that we encounter are the TRA malformations, or isolated syringomyelia, T3rd cord syndrome, certain neurological conditions like cerebral palsy or muscular dystrophy. This is one of our patients who had a TRA malformation with tonsil herniation, basilar invagination and syringomyelia, and the X-ray below is the X-ray showing a thoracic scoliosis. Degenerative scoliosis, as the name suggests, usually occurs in elderly, and it is usually the lumbosacral spine that is most commonly affected, primarily because it is the weight-bearing area of the spine. The problem with these patients is not only the difficulty in the correction of the deformity, but also these patients have multiple comorbidities, which makes the surgery much more tougher. Congenital can be because of two broad problems. Either it can be a failure of formation, as you can see here. There is a failure of formation, so half of the vertebra is not formed. This usually leads to deformity in the form of scoliosis. Or they can be fusion or failure of segmentation. So multiple level of the vertebral body is fused, leading to what is referred to as the failure of segmentation defect or kyphosis. This is both of these are patients of our patients. Iatrogenic usually occurs at the junctional level. In pediatric age group, it is more commonly seen in patients in the cervicothoracic region. In adult, it is more commonly in the dorsal lumbar junction. More commonly, it occurs usually after the following a long surgery, like a intramedullary tumor. In this patient, you can see here, this is the case of who was operated outside for a L1 bony tumor. The patient underwent laminectomy and tumor decompression. Now, 1.5 years later, the patient presented with significant kyphosis. You can see this is the lumbar vertebra, and this is the thoracic vertebra, almost having a 70-degree kyphosis in this patient. In India, one of the most common causes of kyphosis is tubercular, and this is the problem rises even if the patient is getting ATT, perhaps he or she gets the ATT or receives the ATT slightly delayed, and or patient is getting incomplete treatment, that leads to kyphotic deformity in this patient in a later age. Apart from that, the other common causes are ankylosing spondylitis and Schumann's kyphosis. So we recently started doing these cases. For about 2.5 years, we have operated about 26 cases. The most common age group that we encountered was from 16 to 30 years of age. The patient can present with either neurological deficit, pain, or cosmesis, or a combination of them. But importantly to understand is that out of 26 patients, 16 patients presented to us with neurological deficit, that is 60%. Now this is significantly higher than what is reported in the literature, indicating that these patients presented to us pretty late. Initially they were being neglected, either the patient himself or herself, or perhaps the treating physician was unable to find out the exact cause, and the patients were getting delayed treatment. Majority of our patients were having kyphoscoliosis. The most common region was the dorsal or the dorsal lumbar spine, and the congenital, idiopathic and degenerative were the common pathologies that we encountered. In pure kyphosis, the Cobb's angle preoperative as we compare the postoperative reduced by about 50 degree, and in kyphoscoliosis the angle was reduced to about 30 degree. We had our own shares of complications. There were 2 minor complications in form of superficial wound infection, which was managed conservatively, and 2 major complications occurred. Both these patients had deterioration in the neurological power. There was a 15-year-old child who presented to us with progressive scoliosis, and when the patient in the postoperative period, he had deterioration in the power, we got a CT scan. There was a screw which was impinging upon the thoracic spine. So we had to reposition that screw, following which the patient's power improved and the patient is now ambulatory without any support. Another was an 8-year-old child who presented to us with progressive kyphosis, congenital kyphosis, and progressively deteriorating power. The time he presented to us, his power was 2 to 3/5. We took up this patient for surgery, and post-operative there was a deterioration in 2 grade of power. The CT scan was normal, the screws were well placed, so we managed the patient conservatively, and this patient improved eventually. So just representative cases, this is the case of a 20-year-old female patient who was a known case of NF1. She presented to us with progressive scoliosis, and power in both the lower limbs were 4/5, and presented to us with a Cobb's angle of nearly 61 degree. So this is just a brief video. So initially when we, all these surgical procedures have to be done under strict intra-op neuro monitoring. So initially we place the screws. Once the screws are placed, then we have to use various maneuvers. The common maneuvers that are used are the cantilever force. This is the cantilever force is nothing but progressive sequential tightening of the screw, so that the rod, the spine can be given the shape of the rod, which is usually the corrected shape. Then we have distractions and rotations and compressions. So in this patient we are using this. This is we are showing the cantilever force out here. Now once that is done, then we have to derotate the spine, because this kyphosis or scoliosis is usually associated with some form of rotation. So here we are derotating the spine so that it can be further corrected. And we have to, and once that is done, we have to keep the spine in derotated shape, and then we have to tighten the screw. So this is the final picture. So the patient had an improvement in the sensory motor deficit and the power in the 4 limbs of 5/5, and this is the pre-op and the post-op X-ray. At 6 months of follow-up, you can see the corrected clinical image of the patient. This is another case in which there were dual pathology. The patient was a 23-year-old gentleman who presented to us with difficulty in walking for about 3 years. The power in the right upper limb and lower limb was 3/5, and the left side it was 4/5, and the patient has severe spasticity, and the patient was wheelchair bound. The patient had GRE malformation with basilar invagination, and the Cobb's angle was 46 degree. Because the patient had poor respiratory reserve, we decided to take up the patient in 2 stages. So first stage, we managed the GRE malformation and the BI. The patient was tracheostomized and discharged, and the power in the postoperative period was 3/5 in all 4 limbs. He was decannulated about a month later after the discharge, and then we planned the second surgery. The second surgery was the D4 to L2 pedicle screw fixation, and then you can see that the Cobb's angle is nearly normal. The power improved to 4/5, and the tone significantly improved. The important thing was the patient who was preoperatively wheelchair bound, now he is ambulatory, and he is ambulatory with 1 person support, and you can see the clinical picture of the patient here. The third case is the case of a degenerative scoliosis. In this, the patient had grade 1 listhesis at L3, L4. So this is the pre-op and the post-operative X-ray, in which you can see the patient at 15 months of follow-up was absolutely asymptomatic. This is the case of an 80-year-old female. She had a post-tubercular dorsal kyphosis. This is the MRI and the CT. You can see almost a 90-degree bent at here. So you can see the Cobb's ankle was approximately 82-degree. So we did a D7 to L2 pedicle screw fixation, and because there was such a severe kyphosis, we had to do an osteotomy in form of vertebral column dissection and a mesh cage placement. Interestingly, there was a fall in the MEP of this patient during the surgery, so we had to undercorrect the deformity. And once that was done, the MEP was regained. Postoperatively, there was improvement in pain and there was no sensory motor deficit. This is the preoperative and the postoperative CT, and this is the preoperative and the postoperative clinical image of the patient. So to conclude, spinal deformities are relatively uncommon and they can have varied causes. Early referral is very important so that neurological deficit does not occur, and spinal deformity is a correctable cause, and it's a teamwork, and hopefully more neurosurgeons they take up this cause. Thank you.
Thank you, Anant, for that nice review of deformity correction. We'll take the questions in the end. I invite Dr. Tinu Ravi Abraham for his talk on review of current management trends in spondylolisthesis.
A very good morning to all the respected faculty. So, my talk will be on one or two aspects of the current management trends in spondylolisthesis. Now, in this era when the neurosurgeons and orthopedicians are often at tug of war on who will manage spondylolisthesis better, it is to be remembered that in history, it was a Belgian obstetrician who first found the term spondylolisthesis. I will not go through the basic anatomy. Now, what has happened in the classification? Now, all the classifications which were available previously looked at what was obvious only. For example, the Merding classification looked at only the linear translation and it was graded like that. And the Wilsey classification dealt with the etiological aspects or the etiological causes. And the Marchetti and Bortolozzi classification included the developmental aspect, the dysplasia of the bone. It was divided into high dysplasia and low dysplasia into the classification. But what we missed out was, as Dr. S.K. Jain told in the C1C2 joint class he took yesterday, it's not all about the linear translation. It's also about the rotation and flexion which follows the linear translation, and that is not often included in our surgical strategy. Now, this rotational flexion will lead on to lumbosacral kyphosis, and it will lead on to various compensating mechanisms for maintaining a proper spine balance. Now, the compensating mechanisms act at the spinal level. For example, in the cervical spine, it will go in for a hyperlordosis. In the thoracic spine, there will be a reduction in the thoracic kyphosis. There will be retrolisthesis at above levels or proximal levels to the level of listhesis. There will be reduction in the lumbar lordosis. The pelvis will go in for a retroversion, and in the lower limbs, there will be knee flexion, hamstring tightness, ankle extension. All these are compensatory mechanisms to maintain the spine balance. So, what are the facts we overlook? One is the sacropelvic morphology. So, often in a daily life, we see that humans have a varied shapes of the pelvis. Some may have wide pelvis, some may have narrow pelvis, some have large buttocks, some have a small, flat, heart-shaped buttocks. See, all these are unique to each individual. The individual sacropelvic morphology has to be considered. Why? Because it modulates the geometry of the lumbar spine and it modulates the mechanical stress at lumbosacral junction, especially when listhesis occurs. Then you have to remember the fact that there should be a harmonious relationship between the spine and the pelvis to maintain a normal sagittal alignment. Now, then you have to consider the sacropelvic and global spinopelvic alignment. The factors which describe this should be learned when you are when you are doing a pre-op planning itself, because these factors will determine the slip progression and it will help us to plan management. Now, these are the parameters. There are umpteen other parameters, but the important parameters you should assess, which are the pelvic incidence, pelvic tilt, sacral slope, and the relationship between the pelvic incidence and these factors is pelvic incidence is the sum of pelvic tilt and sacral slope. And for a given individual, usually the pelvic incidence will be constant. it will be the inverse relationship between the pelvic tilt and perisacral slope, which tries to maintain sagittal balance. And also, you should all know the concept of a balanced pelvis. What is a balanced pelvis? See, a pelvis in which the compensatory changes, which I described in the slide previously, it will act in such a manner that the C7 plumb line, or which is also called the sagittal vertical axis, will fall exactly on the femoral head or even posterior to the femoral head. In spines where this compensatory mechanism doesn't act, the C7 plumb line will fall much anterior, and that will lead on to an unbalanced pelvis and ultimately an unbalanced spine. Now, so the new classification, it's not exactly new, it has been described about 10 years back, but still we neuroscience haven't taken these classifications into our daily practice. Now, McTeough and Label classification has included, in addition to the grade of listhesis, they have included the dysplasia, the sacropelvic balance into the classification. The sacropelvic balance for low-grade dysplasia or low-grade listhesis are pelvic incidence and sacroslope, and the sacropelvic balance parameters for high-grade listhesis are sacroslope and pelvic tilt. So, 8 types of listhesis has been described, and this has been condensed by the spinal deformity study group classification into low grade and high grade, with the low grade divided into 3 types. One is low grade with low pelvic incidence, which is less than 45 degrees, which is also called the nutcracker type. The importance is that the slip progression is, the chance is very less. So, we can prognosticate and help make a decision whether to fuse or not, or continue with conservative like that. Then there is normal pelvic incidence, which is 45 to around 60 degrees. Then there is a third variety where the pelvic incidence is high, which means the shear stress across the lumbosacral junction is going to be very high. So, these people, the chance of progression to a high grade is very high. So, that is 3 types. Then high grade is divided into balanced and unbalanced sacropelvic or spinopelvic balance. So, this was one of the main points of my presentation, which you should try to inculcate in your daily practice. Try to include this balance parameter also into your classification. Now, how do you decide to operate or not? You should know the risk factors which are associated with progression of slip. The clinical risk factors are mainly the age at presentation, young age, female sex, symptomatic patients, and postural or gait abnormality. The radiological parameters, all this, that is the dysplastic variety, vertical sacrum, more than 50% slip, increased slip angle, and so instability in X-rays. All these are definite risk factors for progression of slip. Now, the conservative management, there is nothing new except that the SPECT has been taken for deciding on the conservative management recently. And the indications of surgery are persistent symptoms even after an adequate trial of conservative treatment. Now, when this persistence of symptoms occur, you should bear in mind that there is some amount of sagittal imbalance, and so you should opt for fusion. Now, obvious or overt sagittal imbalance with postural deformity, any neurological deficit, and a skeletally immature patient with a more than 50% slip, or a skeletally mature patient with more than 75% slip should undergo fusion even if it is asymptomatic. Now, the aims of surgery is not restricted to correction of the slip alone. You should have in your mind, you have to correct the angular deformity, maintain a lumbar lordosis also. So, ultimate aim should be they maintain the sagittal vertical axis or C7 plumb line within 4 cm of the sacrum. Now, how to correct lordosis? Now, pre-operative planning formulas are available, which takes into account the pelvic incidence, tilt, lumbar lordosis, and thoracic kyphosis. And from these tables, you can see how much of the length of fusion should you do for a particular patient with a particular pelvic incidence. For example, a 40 degree should undergo this much fusion to attain so much of degree. So, this formula should be made use of before deciding how much of lordosis you want to correct. Then the osteotomies. As with adult deformity, the Pondis osteotomy, pedicle subtraction osteotomy, etc. has to be included. And also the operative position should be, as far as possible, a lordotic position should be maintained. Release procedures should be planned accordingly. Then the instrumentation, the contouring of the rod according to the lordotic angle you measured. Yes. Various surgical options are available. The past defect repairs are not now favored, that's my knowledge. In situ pedicle screw techniques, direct pedicular body fixation in irreducible listhesis, that is from you can see in the lower screw passes from the inferior pedicle to the slipped vertebra above. Then interbody fusion cages, A-lift, PLIF, T-lift, various cages are available now. Even lordotic cages are available. Spondylectomy procedure is one of this thing. And a brief slide on our institutional experience. From the period 2016 to 2022, we operated 60 cases in which L5S1 listhesis predominated, with a female predominance also. And we have been doing all sorts of listhesis, open, mini-open, MIS, T-lift, MIS percutaneous in that chronological order. From the previous days in which incisions used to extend from 16 to 20 centimeter, we have converted to mini-open and now MIS, T-lift and also percutaneous T-lift latest. So the take-home message which I wanted to convey is failure to account for global spinal alignment and spinopelvic parameters when treating spondylolisthesis will lead to treatment failure and the risk of a future residual deformity. Lordosis correction through appropriate techniques should be included alongside the conventional slip correction to avoid a failback syndrome later. Thank you all.
Thank you, Tinu, for making a complicated topic less complicated. We invite next speaker is Anup, no? Dr. Anup for minimally invasive posterior spinal foraminotomy.
Very good. Okay, thank you. Yeah, a very good morning. First of all, thanks. A big thanks to the organizing person, organizing chairman, and the whole team for giving me an opportunity to stand on this podium and give a talk. So I would be just coming on from the major surgeries of spine, the big surgeries. I'm just coming to a small minimally invasive procedure that I've been doing over the past 3 to 4 years, which I feel is much rewarding. So my topic for the day is minimally invasive posterior cervical foraminotomy. Yeah. So we all know that cervical radiculopathy usually presents as. Excuse me. Can I have this a big slide? Can you expand this? This is the only thing. Use slideshow. Yeah. Thank you. Yeah. Sorry for the delay. So cervical radiculopathy can usually present as a radiating pain, paresthesia, motor weakness, and of course diminished reflexes. The options are varied. You can either have surgery, physiotherapy, and of course medications and blocks. Surgery, they can be either fusion or motion preserving surgeries. ACDF we all know is the gold standard for decades, and motion preserve is of course artificial disc replacement or the posterior cervical foraminotomies. Again, coming back to surgical, they can be either anterior or posterior. As I told you, ACDF, anterior foraminotomy, and ADR, artificial disc replacement, are the anterior options. The problems we all know or we all have faced in our earlier careers and we all have improved over the past, basically post-op dysphagia, rectal nerve palsy, adjacent segment diseases, cost, graft issues, and pseudoarthrosis. So coming to my topic per se, the posterior cervical foraminotomy was first described as Scoville and Sperling in 1944. Though the procedure was described in 1940, was basically an open posterior cervical foraminotomy, and due to the disadvantages that it had in the post-operative period, it was slowly abandoned. And then came the importance of minimally invasive posterior cervical foraminotomy or the minimally invasive posterior cervical foraminotomy with a discectomy. Spine surgery is actually evolving from big names to short forms, so you find a lot of new short forms in spine surgery, so this is one of them. The advantages what they found in the minimally invasive, as we all know, is a less pain, faster recovery, and immediate return to work, and of course, motion preserving. So in 1983, Williams was the first to describe or present a paper on posterior cervical foraminotomy, where he published his studies where he found that 96.5% of his patients, they had a resolution in symptoms in just 3 days. And the key strategies that he took or he was evolved was preserving soft tissues, ligaments, bony facets without compromising the foraminal decompression. So as a short illustration or a pointer. So yeah, so this is what is meant, or pictorial representation of what we mean by posterior foraminotomy. You you identify the laminofascicular junction, stay immediate to the facet, drill a part of it, and you expose the foramen, and you say the nerve root as visualized. This is another pictorial representation showing the relation of the herniated disc with the nerve root and the pedicles on the superior as well as the inferior aspect. Indications are very important in choosing this procedure. Usually it's usually utilized for a lateral disc herniation or a foraminal stenosis. Intraforaminal soft or hard discs, provided that more than 2/3 of that disc is lateral to the thecal sac. Bony narrowing of the of the root canal, it can be either used due to a bony, the hypertrophied part of the facet or the osteophyte. Relative indications, an intraforaminal cyst or a tumor. More than the indications, I would like to focus on the contraindications because it's not suitable for a median or a paramedian pathology. If you have kyphotic malalignment or instability at the index level, anomalous vertebrae relative one, ossification of the posterior ligament, and of course relative contraindication of the recurrent disc and bilateral pathology. A small pictorial or a diagrammatic or a radiological representation of what is in what is the indication and what do you aim at your posterior foraminotomy is, you identify the laminofascicular junction and drill that part, thereby freeing the foramen, scoop the disc from the axilla, and thereby your nerve root is free. I always prefer to do a preoperative CT scan before my surgery just to avoid any intraoperative unknown issues or So this is an excision of idiom which we tried, same. So this is an indication of a C6, C7 disc wherein it's a good case for a posterior foramen and the central one is a bad one. It's a contraindication. So this is a pictorial representation again to show which zones is good. It is said that more than, if you draw a line to the midline of a facet, if you drill more than 50% of facet, that can cause instability. So that case is not a good candidate for posterior foraminotomy. So those discs which are in the blue one as well as the red one, the blue one is an absolute contraindication. The red one, they say that it's basically hypertrophied osteophyte, or there's osteophyte which is causing the foraminal stenosis. In those cases, the recurrence rate after posterior foraminotomy is high. So the orange and green ones are better ones where you can definitely go for a posterior foraminotomy. Patient information or patient counseling is very much important in choosing this surgery. The conventional risk of course, of cervical disc surgery has to be told. Post-surgical segmental instability for which he might need to undergo a redo surgery has to be explained in detail. Pre-op evaluation of course involves an X-ray, MRI and CT scan is necessary. These are requirements during the surgery. You can either use a tubular retractor system which I have been using, and of course now it's a day of the endoscope, so endoscope system is also equally good. The positioning can be either in the semi-sitting or in the prone position. Heads are fixed on frames. You take the X-ray in the AP as well as the lateral view. These are tubular gadgets. Intraoperative marking is required with either the needle or the K-wire, and then the serial tube dilators are placed, and at each point it is checked to confirm with your intraoperative radiology. You insert your tubular system sequentially into this, and once I use the 18 mm port, the tubular dilator, and once that's secured, it's placed, and then this is your area of you get the vision or what you see after the tubular dilator is inserted and your muscles and soft tissues are dissected out. So they say that you get a V-like shape which is formed by the V is formed by the superior and the inferior lamina, and the junction, you should identify the facetolamina junction. The drilling starts there and extends medially, superiorly, inferiorly. And finally, you find out the nerve root, and a hook is passed beneath the nerve root, mainly from the axilla. Unlike the lumbar area, here the axilla is attacked more easily, and then the nerve root is, the disc is scooped out and your nerve root is free. So on table itself, you can, the immediate decompressed nerve is visualized and your surgery is over. Immediate post-op recovery, you discharge the patient the same day or the next day morning. No routine imaging is required and the patient is back to work as early as possible. Of course, hazards, extensive drilling can cause more instability. Bipolar coagulation can cause damage to vessels, and of course, some form of cord issues as well. So this was excessive drilling that caused increased loss of your facet, for which we had to undergo a redo surgery. This is one of the complications that literature says that excessive coagulation use can cause some amount of cord injury. So the advantages, as I told, are all the disadvantages that we get in an anterior surgery is dysphagia, hematoma, recurrent lumbar palsy, instrument in issues, adjacent segment issues. The disadvantages, neck pain, blood loss, CSF leaks. Coming to the literature, they say that minimally invasive post-cervical foraminectomy is not a replacement for ECDF. It can be considered an alternative in selected cases, and some amount of advantages has been told in PCF, where they find that there's a low rate of 1.1% surgeries at the index level. And of course, when they compared the ACDF, PCF as well as artificial disc replacement, they found that the advantage is that the range of movements was much easier in post-surgery in the posterior cervical foraminectomy. Of course, some of my surgeons, they favor anti-cervical foraminectomy, but anti-cervical foraminectomy over the subsequent years, they have found that the radiological parameters, there's some amount of dip wherein the cervical lordosis as well as disc height reduction has been noted in cases. So to conclude, it's an excellent alternative to ACDF. Results are promising as spine is now the daycare spine surgery is evolving in rough light centers. Case selection should be the utmost priority, and of course your patient counseling is utmost important. Thank you.
Thank you, Anip, for the nice review of the posterior cervical foraminectomy. We now go on to the next speaker, C1, C2 fixation, adult versus pediatric challenges and strategies. Dr. Sunil Kumar.
Respected Chair, senior faculties, teachers and colleagues, good morning. My topic is C1, C2 fixation, adult versus pediatric. What are the challenges and strategies faced by me? And regarding C1, C2 fixation, it's a complex surgery, and attandoaxial instability is the major indication for a fixation. And for fixation, reduction, joint decortication, and adequate grafting and rigid fixation is the aim of the surgery. And classification, all you know, our important thing in this classification is it reducible or not reducible? And also the subluxation. It's already said that rotary subluxation, which is most commonly seen, is most important in this C1, C2 fixation. And approaches, all you know, anterior approach, posterior approach. Mostly we go for the posterior approach, and sometime we'll have to go for an anterior approach. And different the approaches, the transarticular screw or interarticular screw. Earlier there was sublaminar wiring, and anterior approach also there is transarticular screw and interarticular screw and plate fixation and rod fixation is there. Different kind of fixation is there in C1, C2 region. And the posterior approach, just to show the anatomy, you can see the facet joint, the C2 root and ganglion, and the vertebral artery and the venous plexus. This is one thing more important when you go for a posterior fixation. And for a transarticular fixation, you will have to go through the C2, through the joint to the C1. And these are already described methods. There are different methods in C1, C2 fixation. And of course, C1 is lateral mass, the screw is placed in the lateral mass, and C2 you can place it in pedicle, pars, or in the lamina. This is the pars where you put screw. This is a pedicle, you go pedicle, you can go beyond the pedicle to the body also. And this is translaminar. If you required, you can go for a translaminar fixation. And anterior approach, almost same. Transpedicular screw, you can go from the anterior, and this is the CT after fixation. This is in between two joints, you can go for a interarticular screw and plate fixation. This is the perioperative X-ray of that anterior fixation. And regarding pediatric C1, C2 fixation, we have 5 patients, not much experience, but having difficulties in doing all these cases. And we have done posterior wiring for 3 cases, and C1, C2 screw and rod system in 3 cases, and in one case we have failed to do a C1, C2 fixation and gone for a occipital cervical fusion. And this is our statistics. The age range start from 5 years to 11 years, and one patient was female, the other was male. And for indications are, most of them are AADs, and one thing with the rotational subluxation, and one unstable C2 fracture, and one case was basilar invagination. And two patients, there was no neurological deficit, and the other three patients have neurological deficit. We have gone posteriorly in all the cases, and follow-up is maximum is 4 years and minimum is 3 months, and bony fusion in almost all cases we can achieve bony fusion. And regarding remarks, two cases were Down syndrome and syndromic cases, and one case there was a extensive rotary subluxation. And this is on clinical scenario, 9-year-old boy with basilar invagination with myelopathy, and we have tried for a C1, C2 fixation but failed, so we will have to go for a C0, C2 fixation done. This is the pre-op CT, and why that failed? Because of assimilation, mostly due to the fibrous tissue. There was C0, C1 assimilation, so we can't get screws in the C1. This is the pre-op and post-op comparison. It's well reduced and the patient improved also, clinically also improved. The next case, 11-year-old boy presented with road traffic accident. He has an unstable odontoid fracture with C1, C2 joint subluxation bilaterally, but there is no neurological deficit. This is the CT. You can see the obliquity of the fracture and comminuted fracture there, and both sides, the C1, C2 joints are subluxated. And we have done C1, C2 fixation with the screws and rods, and also adequate grafting is done, and graft was placed with the wires. And the third clinical scenario, it's a 11-year-old girl with pain and restricted movement for the neck for the 6 months, no trauma history, but developed quadriplegia over a period of 1 week. And there was grade 3 power in all limbs. And this is the radiology. You can see the dents, the posterior placement of the dents. And in the axial cut, you can see the rotation, the C1 and C2 rotation. The rotation is, C1 rotation is almost 40 degree. And in the 3D CT, you can see and feel the rotation. You can see the posterior tubercle in the lateral part. The C1 is rotated much. And we have done DCER for this patient, and you can see the reduction, almost complete reduction in one direction, but rotation we cannot completely derotate it. And the patient had dramatic neurological improvement, and the patient was, when she discharged, he could walk. Normal power in all limb after 1 month. And pediatric C1, C2 fixation, what are the challenges? The size of the vertebra, the cartilaginous bone, that's mainly screw purchase is not there, and bone graft harvesting, it's a challenge. And rotation, almost there will be some rotation in C1, C2 congenital anomalies, and you will have to get a very good picture of the anatomy. And subperiosteal bleeding, that's one challenge. You cannot wax it because you need that raw area there for a final fusion. And poor healing potential in some risk groups. And cervical arthrodesis in children causes secondary deformity. And regarding the size, you will have the anatomical size should be compatible with the minimum size of the device. We only have the adult size screws, 3.5 system and 4 millimeter system. And the cartilaginous part, both in C1, C2, the screw purchasement is less. So when you do a wiring, when you tight the wire, the lamina can break off. So the wiring the tightening should be minimal. And congenital anomalies, mostly rotation of the C1, C2. And other congenital anomalies, you cannot put screws in easily to C1. And this case, when I have showed that case, the C1 was rotated clockwise for 40 degree and C2 was rotated anti-clockwise 15 degree. So the total rotation was 45 degree. You can see it from the CT. Clockwise rotation of C1 into 40 degree and reverse rotation, anti-clockwise rotation of CT 15, total coming to 55. And they already shown that scan that the posterior tubercle is in the lateral part. And the second case, atlas assimilation, you can see the abnormal position of the vertebral artery. So you will have to know the cause of the vertebral artery before you go for the surgery. And subperiosteal bleeding is there, more than 300 ml in every cases. And poor wound healing already said, and the secondary deformity said. What are the strategies? So we have gone only posterior fixation we have done. And for that, more than 10 years, rigid adult instrumentation can be used. But 3 to 10 years, sublaminar wiring, and if possible, if the size is good, we will go for a pedicle fixation, pedicle or a screw fixation. And for less than 3 years, it's difficult to fix. And size of the vertebra, you should have to assess by CT, 3D CT, and only adult screw is possible. And there is a very little margin for placing the screw. And cartilaginous part of C2, that's, you can use a high pitch screw and bicortical purchase. Just engage the cortex, not pierce the far cortex. And optimal tightening of the wire. And graft harvesting, it's a difficult thing. Bone graft harvesting is difficult because of thick cartilage. So periosteum is elevated and a piece of cartilage is removed, and then enough bone is harvested. Then cartilage is resutured with periosteum. And we can use the other grafts also with allograft, autograft, etc. And extensive graft filling is needed. And we will have to go for a CT angio before all surgery to see the vertebral artery position. And you can see such cases, such high riding vertebral artery. And drilling of the irreducible joint is one important thing. You will have to make it a congruent one, remodel of the joint before you go for a fixation. And pseudo facets are there. If there is pseudo facet, you would have to clear that and place graft in the pseudo joint also to get maximum fixation. And the other strategies, definitely you will have to go for a neuro navigation, neuro monitoring, reduction. Reduction is an important thing, and manipulation. Manipulation you can try for an AP translation or a rotational translation you can try before fixing it. And the message is, surgery in C1, C2 areas of the pediatric spine is difficult and complex. Proper surgical planning based on an accurate study of the anatomy, combining information from plain X-ray, CT scan, MRI and 3D CT, angiography or angio CT to find out the cause and variation of vertebral artery. Reduction, copious grafting, rigid fixation are the key factors of rigid bone fusion. The expertise and experience of the surgeon are the most important factors, and adequate experience in adult C1, C2 fixation before trying a pediatric one. Thank you.
Thank you, Dr. Sunil, for sharing your experience with a complicated topic, especially the pediatric ones. Thank you, Sunil. Next, we call upon Dr. Ajit to discuss on fully endoscopic interlaminar approach to lumbar disc. Ajit, two things, and he has been pioneer and starting on minimally invasive neurosurgery with endospine techniques. Now he is using endoscopic techniques, and it's a great thing for neurosurgeons always to adapt to new things. Dr. Ajit, please.
Good morning, seniors, my dear colleagues and senior faculty members. Thanks to organizers for inviting me for this scientific event. You asked why endoscopic discectomy, because there are a lot of ways, microlumbar discectomy, tube discectomy, but this is the least invasive and the most comfortable for the patient, because the incision, the main problem with any spine procedure is access related morbidity. So I just come to the next topic. This is the algorithm for lumbar disc herniation in the present endoscopic era, because most of the cases can be done by extraforaminal, transforaminal or interforaminal techniques, and this is the most commonly practiced way in India. But from where it originated, only 35% of cases are being done by foraminal technique. There are a lot of limitations for the foraminal technique. One of the major limitation of foraminal technique is the injury to the exiting nerve, because you can see this is the exiting nerve root, and you see this is a blind technique. Whenever you are introducing a 8 mm cannula sleeve through the flanks and navigating it almost 13-14 centimeter, even if you give a lot of local anesthetics and under sedation, it is really uncomfortable for the patient. And the controversy is still there, whether it should be done under local anesthesia, whether it should be done in GI is still there. And it is, unless you become a top expert, there will be definitely damage to the exiting nerve root. Another limiting factor is the iliac crust, which will prevent the access of the foramen when it is L5 S1 region. And mobility, you see this is a foramen, and we will go through the lower part of the foramen. So what happens, the scope cannot be manipulated in the lower part, there are the bony confines all around. And of course the hard structures, just like anterior osteophytes, the thickened facet joint, these all prevent your access and your mobility when you do a transforaminal, interforaminal or extraforaminal technique. The interlaminar technique is similar to what is familiar to all of us, all of the neurosurgeons, the same what we do for a tube. And what we do, we use a 25-degree lens system and the technique is same. First you open it, medialize the nerve, and then explore the area of the disc prolapse where it is in the recess at the level of disc, etc. And how you do this? This is the localization of the entry point. First you take a AP, then identify the L5 S1 or L4 5 or L3 for wherever you want to do the discectomy. Then identify the ligamentum flavum area. This is the ligamentum flavum area. Then you identify the spinous process, both spinous process. And middle of the spinous process is the usually entry point. It is little off center because 2 to 3 centimeter lateral to this. Then introduce the scope, introduce the dilator, and dilator should be laterally directed. And actually this hits the facet joint, and the facet joint act as a hypomohelion which prevent further advancement of the sheath into the nerve root or causing damage. Then coming to the entry point, if it's a caudal pathology, caudally migrated disc, it's a cranial approach. If it is a cranial pathology, go caudal, because the trajectory of the scope you cannot predict when it reaches the lower part in the required area. And these are steps of the interlaminar approach, but put the skin incision according to your planning, then introduce the dilator, this is the dilator, and take a X-ray, take a image intensive view, then introduce the dilator. Dilator is something with a beveled edge. Then you check with the lateral, again you check with the lateral, because many times the trajectory can go to the next level. So always before doing all these things, before check the lateral X-ray also. Now the standard procedure, then open the ligamentum flavum. One of the technique by which you open the ligamentum flavum, you with the sheath you make the ligamentum flavum taut, then use the cutter. Otherwise the cutter will slip away over the ligamentum flavum and cut the ligamentum flavum in a medial direction, and until you reach a superior ascending process and descending process of the facet joints. And this is the video, video is not. Video is not working. So the preparation of the ligamentum flavum, opening of the ligamentum flavum, preparation of neural structures and recesses, move the neural structures medial, and preparation and resection of the herniated material, cleaning the area. These are the steps. These are the videos. This is the video which shows you are cutting the lateral part, and this is the incision. This is almost the incision, almost 8 millimeter. Then after cutting the lateral bony confines and medialize the traversing structures, you can see the most important, this is one of the most important point, medializing the neural structures, because there are a lot of adhesions. So when you, instead of medialization or dissecting, when you put the scope, there will be a lot of bleeding. To prevent that, you medialize, wait for some time, stop the bleeding, and then do the rest of the procedure. This is how you take the disc out. You can see after medializing, releasing the traversing route, you can use your the forceps as a retractor, or you can further advance the sheath, and with the sheath you can medialize the nerve root. And after that, you can see the nerve root pulsating, and usually when you start, the nerve root will be flat. When after adequate decompression, it will become rounded, and these are all the indications of adequate decompression. This is one important step, because when you do this, you put a dissector and medialize the nerve root, then over the dissector you advance the sheath, and the bevel edge should advance till the nerve root, then rotate it medially, so that the sheath can be used as a thing to retract the nerve roots. So you can get enough space, you can use your instruments with a much more peace. And if you find in the L3, L4 and L4-5, if there is no enough space, you can dissect the bony bones, and you can dissect the superior ascending process, inferior ascending process, superior and inferior lamina, and widen the bony window. The widening bony window is important in preventing the squeezing of the nerve root. And these are the indications for widening the interlaminar window, small interlaminar window, cranial levels, that is L3, 4, L4, 5, L3, 4, L2, 3 and above, narrowed recess and medial herniation, etc. And again I am reiterating, these are the contraindications for difficulties for a transforaminal route, that is exiting route, iliac crest, mobility, heart structures, cranial stenosis. For interlaminar there is no restriction, and you can move the endoscope just like a joystick. And at the end, this is what is proposed by the consensus. 65% of cases you can do by interlaminar. Of course, foraminal is the first choice because it's an easier technique, but the chances of injury to the nerve root is more. And when you become more experienced, you can first do the foraminal technique. And one of the beauty with interlaminar technique is almost all cases that can be done by the foraminal technique can be done by the interlaminar technique. And the complication rates are becoming less, and dural injury also less with the fully endoscopic technique. And the learning curve, you at least need 10 cases before you become an expert in that. And now there is a worldwide growth of almost 18% of the market, that is the statistics, is being done by endoscopic techniques. And these are the new technical advances, and one of the most important is the wireless scope that we will give to the convenience of when we do the cases. And more and more young people are getting into the field, and I think this will be the future of disc surgery for disc, lumbar canal stenosis, as well as for some extradural spinal tumors. This is my experience. I have almost 31 cases of this L5-S126, L4-5-4 and L3-4-2, and 2 tumors, that is extradural tumors, are done with this technique. The complications are tiny dural layer that doesn't require any intervention, and there is a conversion into tube 4 cases, that is in the initial stage. Thank you.
Thank you very much, Dr. Ajit, for that very nice illustration of this relatively new technique of endoscopic interlaminar discectomy. We call upon the next speaker now, Professor Venu Gopal, for his talk on right-sided extrapharyngeal approach for fixation of atlantoaxial joints.
This one. Project. Extended. Windows only.
Second screen only, or then the screen will not come.
It is a duplicate only I put. Yes, sir. Why it is okay?
Respected chairpersons, a good morning, very good morning to all. At the outset, let me take this opportunity to thank the organizing committee for giving me this opportunity. As you all know, posterior approach to atlantoaxial fixation is the gold standard. Here I will share my experience, limited experience of a varied technique, anterior retropharyngeal approach for fixation of bilateral atlantoaxial joints. Even though posterior approach is the gold standard, it has many problems associated with it. One is the risk of vertebral artery injury. And as you all know that vertebral artery has got a complex course, and because of this, various anomalies are also there for vertebral artery. It can be a high riding vertebral artery, or the vertebral artery can come in directly in front of the atlantoaxial joints, which can get inadvertently injured during the procedure. Also, there is disruption of the posterior ligamentous complex and the C2 nerve root denervation, which leads to further instability. Also, there are associated problems of bleeding from the suboccipital venous plexus which will be very messy and difficult to manage by an inexperienced surgeon. And the posterior approach, the prone position, is also not physiological. It has its own complications leading to spinal cord ischemia along with hemodynamic instability. So we had thought of a varied technique of anteriorly approaching the atlantoaxial joint. That anterior approach has a lot of advantages, like it is a retropharyngeal approach, it is intermuscular, do not disrupt the posterior ligamentous complex, and also we can proceed without any fear of vertebral artery injury or the intervertebral venous plexus. Also, the position is supine, which is more physiological also. And we can use this approach for irreducible atlantoaxial dislocations and basilar invagination. Here we use a low-cost device, which is a polyslotted plate and self-tapping screws along with cage, by which you can reduce the basilar invagination. And this approach can also be used for other concomitant anterior pathologies like odontoid fractures. If you can also do an odontoid decompression, and you can address other subaxial pathologies along with the anterior approach. So coming to the preoperative evaluation, we need a dynamic lateral X-ray to confirm, because it is just technically difficult to approach this area if the angle of mandible is below the body of C2. Should be above the body of C2 to reach the joint. And we also need a virtual reality axial and sagittal three-dimensional computerized tomographic images along with the angiogram inscribed into it, so that it will be easy, it will help you during the procedure. The position is supine with the head in extension. You can even strap the neck to open up the corridor between the head and neck. And I use a Mayfield clamp also. The Mayfield clamp should be away from the table, and it is preferable to use a radiolucent table also. Depending upon your OT setup, you can use a biplanar C-arm or a C-arm. You can use AP as well as lateral alternatively. The surgeon can sit comfortably on the right side of the patient with the assistant on the left side, with the scrub nurse and trolley on the left caudal end of the patient, with the anesthesia machine and anesthetist on the right caudal end of the patient. So we'll come to the operative steps. The incision is a curvilinear incision 2 cm below the angle of mandible, just to preserve the marginal mandibular nerve. And just like an anterior cervical discectomy, you raise a subplatysmal flap, and once you raise the subplatysmal flap, you will see the submandibular ganglia. Anyone who had done the submandibular sialadenotomy can easily do this procedure. Once you incise the fascia below the submandibular gland, you will be seeing the digastric tendon, and immediately below the anterior belly of the digastric will be the hypoglossal nerve. I prefer to dissect the hypoglossal nerve fully so as to avoid neuropraxia after the procedure. The anatomy is fairly constant and you can easily see the hypoglossal nerve. And after that, you dissect in between the carotid laterally and the superior constrictor medially, and you will reach a loose areolar tissue. And once you open the loose areolar tissue, you will be directly over the prevertebral fascia and the C2 body. These various size Langenbeck retractors are very useful in such procedures. And one important thing is that there is bulk longus colli muscles on both sides of the C2 body, which will be converging also when you reach the upper part of the atlas. So you will have to dissect it out subperiously onto the both sides, or in some cases we will have to cut the longus colli using a low current monopolar to expose the atlantoaxial joints. So I will come to the video. Here you can let me orient. This is the right side with the carotid and sternomastoid on the right side. I am putting the Langenbeck retractor. Usually dynamic retraction is useful to prevent praxia of the hypoglossal nerve. Once you open up the corridor, you will be directly seeing the C2 body, and on both sides there will be the longus colli. You will have to retract it or dissect it from the C2 body using low current bipolar. Here I am using a streamline retractor. You can replace it and use a Langenbeck also. It's better to use a low current bipolar. There will be the virtual reality images preoperatively will help you in identifying the irregularities on the C2 body so that you can easily dissect it out. So once you reach the cranial side, it's very difficult to retract the muscle. So once in a while you will have to cut the longus colli also. Later you can resuture it. Only after retracting the muscle you can see the atlantoaxial joints. It's better to see the left side of the joint easily when compared to the right side. Can I fast forward? Fast forward. Can you fast forward? It's a long video, sorry. No, let it go. It's okay. It's okay. It's okay. Then you can. I am cutting the long muscle. You can very well resuture it after the procedure. So once you retract the muscle, you will see the entire C2 body. You can see the right side, C1 and C2 joint. Remove the soft tissue to open up the joint. You can also use a curette to remove the soft tissues. And in irreducible cases also you can mobilize the atlantoaxial joints. Should curette in such a way that the end plate should bleed so that it help in facilitate bone effusion. This is the left side. Actually it is easy to reach the left side compared to the right side. You can see the interior of the joint. The supine position with extension usually help in reduction of the atlantoaxial joints. Here I have also drilled the C2 body. Subfacetal region I have drilled and reached the joint. This is the right side. The soft tissues are being removed. Now the atlas is moved over the axis. It's almost reduced here. Should expose the lateral mass completely. This is the C1 lateral mass on the left side. You can also see the subfacetal region of the C2. So here I am trying to, I have decorticated the joint and using a trial before putting a cage insert. If it's difficult to put the trial initially, then we will have to drill and make the joint more congruent. So please be careful while drilling because safeguard the esophagus also. The cage should be fully studded with bone graft or G-bone, and it will correct the basilar invagination if any. So after putting the cage, you can put a plate. Once you tighten the screws, the screw will immediately come to the next slot of the poly-slotted plate and correct and give a better compression and bone effusion. This is a video showing how to put the plate. The lower side of the plate should be tilted a little downward, towards the medial side. And the C2 screw should be more medial and not lateral, just to avoid the foramen transversorium. It's better to decorticate and tap the lateral mass before inserting the screw on C1. You can also put an anterior transarticular screw. It's easy to put on the left side compared to the right side. And during putting the screw, transarticular screw, you can even try reduction under neuro monitoring. This is the transarticular screw being put on the right side. These are our limited experiences. We had initially hypoglossal paresis along with mild dysphagia and aspiration. I'm sure as we do more and more cases, all these complications will reduce, and most of these patients are improved also. These are our results. So I will go through some cases. This is bilateral transarticular screws. This is another case of AAD with basilar invagination, bilateral plates. This is another one case of triple screw, odontoid fracture along with the plate and screw fixation. We have also done one extrapharyngeal odontoidectomy for rheumatoid arthritis. The patient came to OPD walking. We had achieved a good fusion also. You can also use a virtual reality image postoperatively to assess the screw position. So even though there are a lot of limitations, so technical difficulties and steeper learning curve, and also we need biochemical feasibility research using anatomical ex vivo constructs and all, still this can be considered a better option, almost an equal good option compared to posterior atlantoaxial fixation. Thank you so much.
So thank you, Dr. Vinu, for the excellent presentation and videos. I call upon the last speaker of the morning, Dr. Anup Thomas, to give his talk on minimally invasive excision of spinal IDEA.
Good morning, everyone. Sorry for the delay. I would like to thank the organizers for the kind invite. So my topic is minimally invasive or keyhole IDM surgery. Minimally invasive surgery is a term which is cutting across almost all surgical specialties, the essence of which is to reduce the approach-related morbidity. So while the disease control remaining the same, we attempt to reduce the collateral damage. And this is possible because of the better illumination that we have, better magnification that we have, and other technologies like neuromonitoring. So unlike in other specialties, we don't have a empty cavity to work on, or we don't have a natural orifice to address the spine. So basically it is muscle splitting approaches and limited bone removal that in essence is the minimally invasive surgery to us. So the long retraction and the muscle crush injury resulting is avoided, and less of bone are being removed, and preservation of the ligamentous and the bony anatomy preserves better stability of the spine. So it has evolved to the tubular discectomy, wherein we can do same amount of disc removal as in we do a microscopic disc excision. So how about the laminectomy for spinal tumors? We routinely apply that, but the side effects of which are increasingly recognized in that there is a large midline incision, extensive denervation of the muscles, and bilateral laminectomy and needs to be done along with the removal of the ligamentous structures that can result in long-term stability issues. But still we need to use that for multi-level tumors like this. So it involves advantages of laminectomy, or it is a familiar exposure and you have a commanding view of the surgical field. But it involves dissection of the midline spinous ligament, greater blood loss, delayed segmental instability chances are there, postoperative axial pain, and this post-laminectomy kyphosis is a well-recognized complication. To address this, there are different methods which are available. One of that is laminoplasty or limited placing the lamina back, but that still involves the stripping and denervation of the muscles. But there is a lot of time needed for the procedure, and sometimes it has a risk of dural injury as well. So the technique of less and less bone removal is being recognized. We can address or we can achieve the same amount of tumor excision in an open approach also with a limited bone removal like a hemilaminectomy. This is a pictorial representation of that. So one side lamina is exposed along with the one-sided muscle exposure so that the ligamentous structures is maintained. So this has been shown to improve there is shorter surgical stays and better stabilization of the spine post-operatively. So how we do? So combining these two, the tubular techniques along with limited bone removal, we can address the intradural extramedullary tumors, at least some of the selected ones, in a better way. So case selection is utmost importance. It depends on the sagittal extent of the tumor as of now or as of the technological standpoint. We can address the tumors which are limited to 1 or 2 levels. And relationship to the spinal cord is also important. When it is located anterior to the spinal cord, excision by a minimally invasive approach is difficult. Also, a predictable histology is better when we are addressing intradural extramedullary tumors. Most of them are either schwannomas or meningiomas, and it's better to select cases with a typical radiological appearance, at least initially. And level of tumor is also important because in the lumbar, the caudal nerve roots are better adjusting, but in the dorsal and cervical levels, the spine may not tolerate many manipulations, the spinal cord. So the images needs to be looked on, and you have to plan the side of approach depending upon the laterality of the tumor, and the dorsal location of the tumor should be ascertained. And the type of the tumor, you should have an idea what you are going to deal with, and you should have a strategy also. So as in any minimally invasive surgery, we depend a lot on the radiological appearance. So level has to be confirmed, reconfirmed many a times, because extending the incision and extending one or level up or below is usually not possible in a tubular retractor surgery. So especially important in dorsal surgeries, you have to count the number of lumbar vertebra, you have to see the number of ribs that you have, and you can use ribs as a landmark in thoracic levels. And navigation will also help. CM confirmation intraoperatively at multiple stables will be required, because slightest angulation you can go to a different level. So surgical steps are similar to what we have in open surgery. Patient is position prone with head fixation for cervical and upper thoracic lesions, and a paramedian incision of 2 to 2.5 centimeters usually. And the level of tubular retractor docking needs to be ascertained. You have to see the facet joint laterally and the spinous process medially. So you can open the fascia and the muscle docking can be done. Then with the help of operating microscope, further steps take place, and from here on, except for the limited bone removal, it is much same to the open surgery. So the corridor is little difficult, but you can manage most of the things. And the dura is usually opened in the paramedian level, paramedian site, and the usual microsurgical techniques can be applied, piecemeal removal and slowly mobilizing the tumor out of the surgical or the intradural component. And you should visualize the superior and inferior pole of the tumor. The cord should also be, the integrity of the cord should be checked on. And after that, the tumor excision, the dural closure is the important step. You may require extra bit of bone work when you are addressing it through a hemilaminectomy. So sometimes a little bit of the facet can be removed without affecting the stability. Drilling of the base of the spinous process gives an extra room, and undercutting of the above or below lamina also gives a much required space. So other strategies depending on the type of the tumor. Schwannoma, you need to coagulate the nerve root of origin. Meningioma, you can preferably coagulate the dural attachment. If possible, you can excise, but it sometimes will be very difficult, especially through the tube. For the dural closure is sometimes we have a struggle. So the usual suturing techniques may not apply, although you can take time and suture that back. There are easier ways like application of LIGO clips and application of dural substitutes. Sometimes the arachnoid adhesions can trouble you. So the pseudomonas meningiomas can sometimes invade the pia and the dissection can be difficult. So these are benign tumors and the patient's neurological status is of utmost importance. So every effort should be made to preserve the patient. We usually do under neuromonitoring, and slightest change you should be prepared to open also. Various studies have established the advantages like shorter hospital stay, less tissue disruption, less muscle damage, early return to work and blood loss, reduced blood loss. Different papers, one by Ajit sir also. So this is a representative case with a cervical intradural extramedullary lesion. The marking happening. So a short video, I'll rush through that. So this is the tubular docking happening. This is the bone view. You can visualize the limited lamina. So the hemilaminectomy is done by drilling. More bone removal. So that is the dural opening, opened in a paramedian site. After that, the routine surgical steps, make sure that that is a tumor, and some effort if we can to visualize the spinal cord at the cranial or caudal end should be done. So this is the debulking. After a while of debulking, the tumor starts to get mobilized much as in the open procedure. So the upper pole is defined. You can see the tumor starting to come out, but it is still attached to the nerve root. So this is the upper nerve root. So that's tumor being removed. The intradural compartment is okay. So LIGA clips being applied. So it's not the length of the incision that matters, as I affirmed, as I told earlier. It's a neurological integrity of the patient. So any doubt, do not hesitate to convert to open surgery. Another patient with a lumbar IDEM, satisfactory excision. Another cervical case that we recently had, not going into the video. So different technologies like fluoroscopy, neuromonitoring, 3D CM and navigation help us in achieving smaller incisions and better cosmosis results. So it is safe, feasible and effective. The long-term studies needs to be to come out as well. So for a young surgeon adapting to this tubular excision, we can do open hemilaminectomy cases, lumbar first, small dorsally placed tumors, get acquainted with the tubular discectomy, then start using wider retractors and never hesitate to convert. So these are the technologies coming up, virtual and augmented realities, helping you to establish the other vital structures beyond your field of view. Thank you.
Thank you, Dr. Anup. I think we are overshot the time, so we don't have to.
Hello. Call upon the speakers of this session to kindly collect the certificates. Dr. Tinu Ravi Abraham, Dr. Anup P. Nair, Chief guest to kindly hand over the certificates and moment. Dr. Sunil Kumar, Dr. Ajit R. Nair, Professor Vunu Gopal, Dr. Anup Thomas.
Thank you, sir.
We'll be starting off with the next session, titled Young Neurosurgeons Forum. So the chairpersons for this session will be Dr. Girish KM, Dr. Sarla Menon, and Dr. Amitabh Gupta. Since we've already finished the first session, that is a tribute to Dr. Gulza Gupta, we'll be starting off with the second, titled Neurosurgical Publications from Ideas to Print, a Primer.
Hello. Good morning, everyone. So we'll be starting with the young neurosurgeon form in memory of Gulzar Gupta. And the first speaker has some glitch, so probably he will starting directly with the Sanjeev Kumar Gupta, axial endoscopic third ventriculostomy.
Good morning, everyone. Yesterday, I showed the endoscopic clipping of the ecom aneurysm. The real motivation was my technique of extra-axial ETV. So what is the rationale for an extra-axial approach for doing a ETV? Although if it is mostly safe in the expert hands, but may have infrequent but serious complications in 2% of cases. We often assume that the going through the brain during the conventional ETV is innocuous. Is it? Let's see that. This is a 2-week post-operated T2 and FLAIR images of a lady who underwent conventional ETV. You can appreciate the brain insult along with the tract, right? Most of the risks are due to its intraaxial nature. The transgression of endoscope violates cerebral cortex, which may predispose to a higher risk of seizure. It may produce a tract-side hematoma, ponychial contusions, and minor intraventricular hemorrhage. Rarely, basilar artery injury is a catastrophe. Mammillary bodies may get injured during fenestration. The irrigation-induced hypothalamic dysfunction may result in cardiovascular and endocrine changes. Conventional ETV is technically difficult in slit ventricle syndrome. Safe negotiation and maneuverability of the endoscope is a formidable task. The foramen of Monro is narrow. Coma creation is really challenging when the premammillary membrane is thick and opaque. Narrow premammillary and prepontine space, especially in case of brainstem glioma, is another issue. During repeat ETV, bad scarring at the third ventricular floor is a nightmare. So what can be the alternative to circumvent all these issues? Can a subfrontal extra-axial approach mitigate these issues? Let's see that. The lamina terminalis fenestration for hydrocephalus was first described by Sir Dendy 100 years ago. In 1963, Scarf reported 70% success in this operation. Dr. Maywoody achieved 100% success with the help of microscope. Transventricular lamina terminalis fenestration using a flexible endoscope has overall success rate of 71% and complication rate of 21%. But this technique requires flexible endoscope in majority along with special skills. So we did this using an endoscope via a supraorbital keyhole approach. In extra-axial ETV, the frontal lobe is dynamically retracted with suction and endoscope till release of CSF. Immense patient is required during initial brain retraction. One should seek help of the anesthetist for brain relaxation. Here you can see the olfactory tract, and here we can see the right optic nerve enclosed in arachnoid membrane. The arachnoid membrane is being sharply opened with arachnoid knife. Sometimes it gets opened with traction only. Further arachnoid dissection is being done toward the opposite optic nerve using hook. I prefer nerve hook as it lifts the arachnoid through which small perforators can be seen. Some minor bleeding may occur from the dura as endoscope and suction grazes against it. This minor bleeding is self-limiting. Being an extraventricular technique, it avoids intraventricular hemorrhage and other complications mentioned earlier. EAETV is a direct approach to the third ventricle. The more arachnoid dissection is required for an unrestricted entry of retraction of the frontal lobe. Here you can appreciate opposite optic nerve. One can do a wide cystonostomy to improve CSF circulation, which is not possible in conventional ETV. ETV connects the third ventricle with chiasmatic cistern. Thus, unlike conventional ETV, the liqueous membrane is not encountered. As you can see, no irrigation is required. It avoids irrigation-induced hypothalamic dysfunctions. Here you can see performing wide cystonostomy help improve CSF circulation. Lamina terminalis is the widest wall of the third ventricle. So narrow prememory space or limited prepontine space is not an issue. Lamina terminalis is a thin sheet of rudimentary gray matter. It stretches from calf to anterior commissure vertically and between the both optic tusk laterally. Careful arachnoid dissection can expose it widely. The average surface area of lamina terminalis is 50 millimeters square, much wider than the prememory membrane. So one can do a wide stoma. Anterior cerebral artery and perforators appears on the visible side of the membrane during EAATV, in contrast to the basilar artery and its perforator, which appears on the blind side of the membrane during conventional ETV. Lamina terminalis is being opened with sharp bayonet forceps, and you can see the thick prememory membrane and deep inside the third ventricle. This is the final look after completion of the procedure. Even with the enormous ventricular dilatation like in children with chronic hydrocephalus, it is possible to go subfrontal. One just need a patient and good anesthesia friend. Invest most of the time gentle frontal lobe retraction. Once the CSF is released, the brain sinks and the rest is like a piece of cake. In this case, lamina terminalis was very thin and bulging and got opened during arachnoid dissection. You can peep inside the third ventricle for mesmerizing anatomy of the posterior clinoid process, third nerve, posterior circulation, the thin and pulsating prememory membrane. In over a year, I have successfully performed this procedure in 44 cases of obstructive triventricular hydrocephalus, including 3 cases of failed conventional ETV, 1 case of slit ventricle syndrome, and 1 case of vertebro-basilar dolichoectasia leading to hydrocephalus. Result has been so far rewarding without any serious complications. The cosmetic outcome is also quite satisfactory. Ventricular indices were significantly reduced in both acute and chronic hydrocephalus. These are the preoperative and postoperative CT scans of the patient with acute hydrocephalus. You can appreciate resolution of hydrocephalus. These are the preoperative and postoperative scans of the patient having chronic hydrocephalus. You can appreciate the significant reduction in ventricular indices on follow-up scans. CSF flow voids were seen through the lamina terminalis fenestration in all cases. Some are shown here. Please focus on the anterior wall of the third ventricle. You can track CSF flow voids from foramen Monro to across the lamina terminalis fenestration. These CSF flow voids were the first ever demonstrated after lamina terminalis fenestration for any etiology. This is a case of vertebro-basilar dolichoectasia, compressing the third ventricle and leading to hydrocephalus. On the T2 FLAIR images, you can appreciate the effacement of sulcal space, suggesting the high intracranial pressure. In the literature, one Turkish neurosurgeon dared to perform conventional ETV but had to back off. Only one Japanese neurosurgeon could perform conventional ETV with success. Rest all cases required shunt. So how to do a safe ETV in this scenario? The solution is extra-axial ETV. You can make a safe fenestration in the lamina terminalis far from the dolichoectatic vessel. These are the preoperative and postoperative image. You can see these are the preoperative and postoperative images. You can see the resolution of the hydrocephalus. Here you can appreciate the reappearance of the sulcal space and CSF flow void through the stoma created. This innovative technique has been published in the JNS last year, and the utility of EATV in slit ventricle syndrome has been published in the operative neurosurgery. So in my experience, EATV is safe and effective alternative to conventional ETV. Thank you for the kind attention.
Thank you for the talk. Next speaker, Dr. Raja K. Kuti.
Okay. At the onset, I thank you very much. The wonderful team who put up such a spectacular. Congratulations. And presentation was mainly for young neuro. All are young at heart, I can see that, but many gray hairs around. No problem, because publishing is an art. Good writing is like a poetry, it just flows. It be Michael Lawton describing AVMs in twist words like freaks of nature, explosions of hemodynamic energy, red fury, dilated arteries converging all from all directions like angry snakes, engorging veins, twisting and throbbing from turbulent shuns, and a glistening arachnoid hill, concealing tangled. Or Professor Jacques Marcos in his one of the recent publications, he sailed the sea of philosophy and wrote about complications. That second one that taxes you from emotions is the preventable complications that make you ponder, question, analyze, replay again and find that moment in the where you go from the path of perfection, there was one, or you make a new discovery, unfortunately, path to perfection that would have left much happier outcome. I would just say, wow, how can somebody write such beautifully? These are gifted writers who are inherently rich with the verbal currency. It comes very natural to them, unlike very few of us. Of course, George William is there. He is one of the blessed guy with this. And you got to have a lot of talent and parallel reading. But for lesser mortals like us, we have to sweat it out with perseverance, reading and motivation. So there should be observation and ideas. You could have just enjoyed the calories instead of making out such a complication, gravity. So where do ideas come from? Ideas come from passion, motivation, reading, from friends or mentors, experience from previous study, and out of the box observations like Guglielmi when he noted the accidental electrolytic detachment of a steel electrode during some treatment. That was the idea that gave him the concept of detachable coils. And also you all know the stories of James Parkinson and Cooper, how they discovered the new for Parkinsonism. And further, Sarabinenko, the father of endovascular neurosurgery, he had this vision of balloon catheters when he saw the May celebrations in Russia. They are all geniuses, but we are children of lesser God, have to steadily read and accumulate knowledge. I'll share a few experiences how I went into writing. Of course, my first mentor in writing was Professor Jacob Alapat from Calicut. And when this interesting case of this lady, when she came into our OPD with a headache, and we did a twist on her, but unfortunately not completed because we had to stop the procedure. And she also had severe thrombocytopenia. I had read somewhere that we'll look out for tranexamic acid, and that is our first case of tranexamic treatment for chronic subdural back in. This was followed by our publication of currently the largest series of tranexamic acid in chronic subdural hematoma. And when this gentleman came to me that he flew from Trivandrum to Qatar with the acute onset of headache, and he was unconscious while he landed in Qatar, and they examined him and found to have a colloid cyst, and he underwent shunt. When I heard this story, all it was deja vu. I thought I had read this somewhere. And when I went back to the literature, yes, it is there. There are only 5 cases of such an ordeal with colloid cyst who have deteriorated and died in flight. And this is the only person alive. So your observations and reading only accumulates this type of knowledge. This is another case where a totally extruded shunt on the abdomen was found 28 years after it came to me. So, and this is a very interesting case of spontaneous change in density of colloid cyst. I remind you there are only 3 case reports in the world who are from Trivandrum. One is from Chitra and another is when we reported it. So reading is the gateway to writing. Nurture the ideas and let them grow within. Build an environment for it to adapt. Make plans and try to accomplish it in action. Join all the free societies in social media and everywhere. They will give a lot of information, and take memberships in various societies also. You will expand your knowledge. And once you have decided, then you stick to the protocol, submit to the IRC event of cycling is inevitable. Once you have started, make it your day one rather than one day. Stick to your protocol. The abstract is the most difficult to write. Precise and meaningful, restrict the words and give maximum information. Introduction is part of the manuscript where you tell the storyline clear and concise. So all know Walid Bajiti, who is the editor-in-chief of the Journal of Vascular Neurology. According to him, 5 sentences introduction. The material methods are how you arrive at the plot, in characters, detailed storyline, explain every twist and turns that you will see. It should be very clear, meaningful, which was mentioned in material methods, and percentage should be mentioned as volume should be mentioned percentage. Table and graphs should be simple, digestible. Discussions is where you pray other to what is relevant to your findings. Do not go after new distractions. Avoid straying. Referencing is the most difficult part when you are a beginner. There are several free softwares that come along now. One is Mendeley, Zotero, of course I use Mendeley. And always keep a master file when you're writing a manuscript, and don't alter that master file ever. If you want to copy that file into another and then make changes. Then export the entire manuscript out of Mendeley before you make any. The do's and don'ts of writing are honestly write your findings, avoid plagiarism. All the softwares designed as of now which plagiarism, they note for continuous 3 or 4 or 5 words in continuity. And fit to the words limit, allow others to criticize freely, other to the principle of publication images. If images qualities are not good, they won't publish it unless it is exceptional. This one video that we presented in Journal of Spine Surgery, they took the article and with many revisions, they finally published it, but without this video. So I told them, though it may not be to the standards of your journal, but you will never see such a footage where you take out the disc after making a hole in the spinous process. They agreed and finally they published it. The don'ts are avoid duplication, unethical practices, fragmentation of results, and plagiarism. This very, what would say, on the left is 2017 where foramen, the foramen oval was studied in detail in 2017. And this is in 2019 when one of the authors from India wrote that. And how unfortunate. When I checked, I received a complaint from the left-sided article, which is from Greece. And when I checked the software, it is 100% plagiarism. So never do that. You don't think you can get away with plagiarism like this. And it's okay if your manuscript is short, provided it is insightful. Make use of writing softwares and language editing services from journals. So start with a medium journal and good journal. Don't sell technology to the West. They have seen it all. And don't give up. 3 into 3, the rule in neurosurgery is no longer applicable because nowadays there is a plethora of journals to which you can send it. And finally, success is going from one failure to another failure without losing enthusiasm. If I don't talk about authorship, this is like an elephant in the room that nobody wants to talk about. When I contacted another institute for a collaborative work, and I told this is my idea and so, would you like to be part of it? The first question that raised was, well, we could be ready, but you first tell me what is my authorship. So everybody is this. ICJME has perfectly laid out the criteria, and if you do not suit that, you are not like. And if you are writing, you are the first order. Give credit to whoever was involved in the writing. There was a non-clinical person, do acknowledge them and stopped full or rented authorship. We'll come across so many ads in Facebook, Twitter like this. Don't fall for it. These are all bogus journals. What is the future of writing? Well, as a executive editor for AJNS, I think it is scary and full of concern. Because when I opened the chat GTP and asked the AI software and asked, write a few 500 words about medulloblastoma, and it came up with this fantastic article in just under 5 minutes. So it is really a thing of concern. There are several others AI programs that will help you in writing, elicit background image for images, paper digest, etc. But the originality should be maintained. But as originality is a byproduct of sincerity. So in the world of writing, if you can't fly, then run. Can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep forward. Very important in academic writing. Utilize every day and contribute something to your article. Okay, with that, I'll end my talk. Thank you very much.
Thank you. Now the next speaker I call upon is clipping of the post-clipping recurrent residual ACOM aneurysm. Professor Dashbat Sahana.
Hello. Good afternoon. I'm Dr. Devobruta Sahana. I'll be talking about clipping of a post-clipping recurrent or residual aneurysm, in this case an ACOM aneurysm. So the overall annual incidence of such post-clipping recurrences is about 0.5%. Even after complete clipping, there can be up to 8% chances of post-clipping recurrences. Now this can occur either because of a new aneurysm arising from the site of a previously clipped aneurysm, because even when the surgeon is sure that he's clipped the aneurysm adequately, there can be up to 6% chances of residual aneurysms. And this occurs primarily because of slippage and sometimes because of inadequate clipping. So the regrowth rate is about a residual aneurysm, or it can be because of a de novo aneurysm arising from the previously clipped side. So over the last 8 years, this is we've encountered just one case of post-clipping recurrence, and we have operated about 252 aneurysms mostly ACOM aneurysm. Now, this is not that big a number compared to what my teachers have and all the experience surgeons have, but it's not that small a number either. And this 0.39% incidence, obviously this does not represent the true picture because we don't have a very good follow-up of all these patients. But nevertheless, this was the first case that we had. And this was a 40-year-old female who presented with subarachnoid hemorrhage, and CT angio showed a bilobed anterosuperiorly directed ACOM aneurysm filling from the right side. Supraorbital mini craniotomy was done to expose the patient, and aneurysm, the two lobes of the aneurysm were clipped using two clips. There was no intraoperative rupture, and the postoperative course was uneventful. She was discharged on the 12th day. 1 year later, she presented back with a rebleed. If you look into literature, the average time for such bleedings to occur is about 10 years, but it varies. It has been reported as early as within 3 to 30 days after clipping, even 8 months, 9 months. So it varies with literature. And the incidence of rebleeding in such patients is about 2% in the first decade. It increases to about 12 to 14% in the next decade. It's slightly less for smaller recurrences, slightly more for larger recurrences. And we did a DSA for this patient. We see bilobed aneurysm again, filling from the right side, no filling from the left side. So the treatment options for such post-clipping recurrences is reclipping of aneurysm, endovascular treatment, bypass surgery with trapping or proximal ligation, and a combined modality of treatment. A review of literature, we did a small review of literature including post-clipping recurrences only, recent articles which offered both clipping and coiling to patients, and we found that irrespective of the treatment modalities, we can get good outcomes in about 84% of cases. And obviously for clipping, the obliteration rates are much higher, but the chances of complications are a little higher compared to clipping alone. So this was discussed with the patients, and we decided to right terminal craniotomy, standard positioning, skin incision. Craniotomy was done. The initial part of salivary dissection, the more distal part, was relatively virgin, and we did not encounter any problems. But as we moved proximal, they were, and frontal lobe was not falling off. Back to proximal dissection, I see an optic part of the also see, and the dissection progressed more medially, and we started seeing the ipsilateral A1. There was a layer of gliotic tissue around it. It was adhered to both the frontal lobe and the optic nerve. A place for proximal clipping was secured. We went further close to the aneurysm base, possible at this time. The basic principles of aneurysm surgery: proximal control, then distal proximal control, iris-rectal, ipsilateral, then down the clip, lot of them. Sharp and one dissection. Okay. Opposite was not much, but angio aneurysm. Opposite also started seeing opposite gyrus rectum. And now is that pale thing that we are dissecting actually the of the clip. We haven't seen contralateral abdominal part of the and neck is also now well defined. Now we have control over all the 4 vessels. So we try a clip placement. The existing clip was hindering its application, so we decided to remove the other clip as well. The idea is to do a dissection around the clip blades and then remove the clip gradually in the same trajectory as it has gone inside. This was gradually taken off. The final clipping is now tried. So the clip was applied, but I was still not sure whether any residue is there or not. So a temporary clip is applied, and I decided to do positioning of the clip, push it a little more inside. This was a redo case, so it's more important to not have a residue this time and not to compromise any of the surrounding vessels. The clip is finally applied and the temporary clip is removed. We can see the ipsilateral A1, we can see both the A2s, and we can see the end of the clips as well. And this was confirmed using ICG. We can see the ipsilateral A1, we can see both the A2s, and there is no filling of the aneurysm. This is the post-op CT scan. She had 2 episodes of seizure, severe vasospasm. So DSA was done on post-op, do very minimal filling of the vessels, but no residual aneurysm. And pneumodipine installation was done, and the patient was fit for discharge on the 15th post-op day. There are many ways to classify recurrent aneurysms. Based on this classification, which is based on the existing and the recurrent planes of reconstruction, ours would be a type 3A, and based on its orientation with the clip, ours would be a type 2 here. So to conclude, the degree of occlusion at the time of first treatment is the most important factor for recurrence. Laterally projecting ACOM aneurysms, they tend to recur more. ECOM aneurysms with fetal circulation also tend to recur more. Younger age, inadequate exposure, incomplete dissection, or injury to proximal or distal vessels during closure, clip application, lead to recurrences and re-rupture. For managing these laterally projecting ACOM aneurysms, some surgeons prefer to take an interhemispheric route because it gives a good view of the laterally projecting dome. But then there are other surgeons who prefer to do a craniotomy only. Temporary clip applications definitely reduce the chances of residual aneurysms. Now the concept of cure after clipping is being questioned here, and surgeons now prefer to do a long-term angio follow-up and screening for these clipped aneurysms. There is no consensus as to what time and when it should be done. Some even prefer to do a lifelong follow-up for these patients. For surgery, some surgeons prefer to take a different approach or a different side to avoid the adhesive areas, and there are others who do it through the same approach. Some surgeons prefer compulsorily to remove the old clips, and there are others who do not. Now, endovascular treatment has come up in a big way with a lot of technological advances, and the opinion of the intervention colleague should also be taken for, especially for complex aneurysms like posterior circulation or fusiform wide neck aneurysms. No matter what treatment option we choose, we should try to give good obliteration rates, because that is the only way we can have this treatment last for as long as possible. And all the existing trials, the big trials, they have their own set of fallacies. So there can be no hard and fast rule that this should be done and this should not be done. And each case has to be individualized and decided upon. Thank you.
Thank you, Dr. Devbrata. The next is intraoperative difficulties and lesson learned by Dr.
with D12L1 epidermolysis. During surgery, cyst was decompressed with minimal population of the cyst wall. Was done. Patient is already improved, but patient has developed recurrence after 6 months. This is the post-op scan. This is the pre-op scan. This scan is post-op scan after 6 months. This is the recurrence of the cyst. So, what should be done? My question to the audience. As I have done cyst wall decompression with biopsy of the wall to rule out the ATPR and extensive population of the cyst wall, as I have done in first test to prevent the recurrence, but patient was neurological deficit because of the thermal injury. But in second case, the lecture population was not done so extensively, but patient was the recurrence. So what should be the plan? Then this is the third case. This is a 35-year female with a left mid trigeminal neuralgia. MRI shows a SCA loop which is compressing into the zone of the trigeminal nerve. Plan is the ambidextrous tapetum patch. But intraoperatively, the vascular loop was found facing the vascular loop was found passing between sensory and motor of the trigeminal nerve. Now what should be the plan? I have no idea. I called the answer. Sir told to create a space around the vessels. But and put small amount of tapetum patch. Post-operative patient pain disappeared, but after 2 months, patient was pain again. But that was due to the tapetum. Then we should always remember the anatomy of tapetum patient nerve complex. That are the same similar anatomy. Vessel is passing between the two nerves. So during surgery, fifth nerve should be identified clearly. Normally the vein of Andy is the landmark. The fifth nerve is just near and below the vein. Then the fourth case is a 45-year female right leg loss, gaze and steadiness, headache and vomiting. On MRI, revealed right sacral lesion compressing the brainstem and extending behind the fourth vertical till the midline. It's hyperintensive need MRI and oxygenous enhancement with extension to the IM. Tumor was sedentary tent. So what should be the approach to this lesion? Retromastoid. But it's difficult to take out the tumor straight from the fourth vertical. So I have done mid-length suboccipital craniotomy and approached the tumor through the global consular approach. And whole tumor was decompressed. Then this is the fifth case, a 20-year male patient that is roadside accident. Here the right side hemiplexis and with aphasia. On CT scan, patient has the right lateral fracture, underlying epidural hypotensity. What will be the diagnosis? Most likely is EDH with an ongoing bleed, that is real sign, or EDH with anemia. But there was other finding on the scan. There is thinning of the bone, which made the diagnosis of EDH doubtful. So we did an urgent MRI. MRI show a lesion which is hypon T1 and hyperon T2 with flare is ISO. There is a mild intraocular enhancement and there is no diffusion restriction. So diagnosis was interneural extraxillary lesion, maybe meningioma, meningiocarcinoma, tuberculoma or mets. But it's intraoperatively found out submural lesion with a good take to the rectoid. It is cartilaginous and character. So histology shows it's a chondrosarcoma. Then 6 years is 45-year male with a progressive vision loss. Patient was operated 2 times for orbital hemangioma and underwent gamma knife. And the patient presented to us with a prognosis with vision loss in December. But after that, patient went to some bowlers and came after 3-4 months with a large prognosis. On MRI, it's a large intraorbital lesion extending to the frontal lobe and guava sinus. Tumor has been orbit and it extends immediately to the nasal cavity and inferior
as a biggest honor to present in front of Professor Suresh Nair sir, and I am still feeling that I am presenting the morning 7 o'clock seminar in front of sir. And I would like to thank Ishwar sir, Jayanand sir, Prakash sir, Krishna Kumar sir, Matthew sir and the whole team for giving me this opportunity, and also George sir for not just teaching neurosurgery but many aspects about the life and which we are carrying. So with this I would like to start this presentation, surgical tips in scoliosis surgery. And this was one of the biggest field when I was in the neurosurgery residency, which I was very much afraid of, and even after that I was afraid to venture into. So I did a fellowship, and after all these studies I want other colleagues to venture into this, because in outside the practice most of the ortho surgeons, they are taking over this. They say that we want to do scoliosis surgery, it's not for neurosurgeons. No, they are making things complex by bringing very complex classifications, speaking about pelvic parameters. So what I have done is I have tried to make it as simple as possible. So first thing before the tips for surgery is decision before the surgery, which case to operate, which curve to operate, and which level to start and which to stop. If you know these three things, then we can do any scoliosis surgery. So when a patient comes to our OPD with scoliosis, first we need to take a standing X-ray and make sure that they are skeletally mature. And once the standing X-ray is there, we need to draw two lines. The central sacrovertebral line and the ilioileal line, and measure the comb. So once we measure the comb, if it is more than 60 degrees and the patient is skeletally mature and we say that no, I am having problem with my cosmosis or pain or any other indication, this is an indication for surgery. So first question we have answered, that which case to operate, that question we have answered. The second question is which curve to operate. For this they have brought in a very complex classifications. So the simple thing is we need to identify the structural curve. What is a structural curve? Any curve which is more than 25 degrees and fail to reduce to less than 25 degrees, the bending film is a structural curve, and that has to be included in our fixation. Whether it is proximal thoracic, mid thoracic or thoracolumbar, any structural curve, if it is there, it has to be included in our fixation. So this is an example of a patient. So the patient has got scoliosis with the main thoracic curve, and there is a straight curve with the proximal thoracic, and also there is a thoracolumbar curve. Similarly, central sacrovertebral line is drawn, and then there is a slight shoulder discrepancy, and the comb angle is measured, it is more than 60 degrees. So this is a surgical case, and now which curve to include in our fixation, we need to take the bending films. So the bending films, the thoracolumbar curve is getting reduced to less than 25 degrees as it was previous. So we need not completely include the lumbar curve. Definitely the main thoracic has to be included, but also the proximal thoracic, it is more than 25 degrees, it has to be included in the curve. So this is the basis of this Menke classification. So structural curve and non-structural curve is they divide into 6 parameters, and the number of modifiers, central sacrovertebral line where it bisects the pedicle, that becomes ABC or modifier, and then the kyphosis gets the positive or negative. So the basic principle of all these things is structural curve has to be included in the fixation. Now the third question is which level to start and which level to stop. So once we draw the central sacrovertebral line, the simple thing is the lower most where it just touches the pedicle, we need to include that, and the top where it just touches between the two pedicle, we need to include this. In this picture, the fusion should extend where the central sacrovertebral line has intersected the pedicle, and the lower most, we need to look at the disc obliquity. It has to be less than 10 degrees. So how to reduce the disc obliquity? We can do compression and distraction at the various levels, and we should make sure that the lower part, the disc has to be parallel, and it should be less than 10 degrees oblique. So after all these things, then we will go into the tips of scoliosis surgery. So following are the steps for any scoliosis surgery. Screw insertion, soft tissue release, start with minimal osteotomies, and curve reduction under neuromonitoring. So first I will start with the screw insertion. We all have to do the freehand medical screw technique, because getting into X-rays and all, CM, we don't have that option, and freehand is the best way to put in a screw. We need to know 3 things: the entry point, medial-lateral angulation, and superior-inferior angulation. Starting from the lumbar spine, the classical teaching was that the entry point for a medical screw is where the But many times when we burn or when we put a dowel in this location and we try to put in the pedicle screw, sometimes we tend to go lateral and we miss the pedicle. So the first and the foremost anatomical landmark we need to identify is the pars. So pars forms the medial border of the pedicle. So pars, once we know that, once we identify the pars, we know that this is the medial border of the pedicle, we should not go beyond that. The second landmark is the midpoint of the facet. So the midpoint of the inferior articular process that forms the topmost part of the pedicle. And the third line is the TP facet junction. So once we have these three lines in our mind, we know that where exactly the pedicle is, and we need to drill or bite or whatever and start putting the pedicle screw in that location. Now this is one image where we see superficially we need to have the 3D image of the pedicle, and then coming to the medial lateral and superior inferior angulation. So the medial lateral angulation we need not very much, just follow the pedicle and try to be bone medial, the screw will be in place. And the superior inferior angulation, then 5 degree for L1 and then add 5 degree for each level. But that is also very difficult to assess. So simple thing is L1 and to L3 almost perpendicular, and L4 and L5 bit of downward angulation, and S1 is both downward and medial angulation as compared to the L5 screw. So it is better to mark the skin with a pen and then at each level see how we are angulating and we can insert. And we should have this iliac screw in our armamentarium because this is essential if you are extending the fixation beyond L1 and above. If you are going for T11 to sacrum, we cannot stop at L5 or S1. We need to include the iliac screws. So to insert the iliac screw in a freehand pedicle technique, we need to identify the posterior superior iliac spine, take a bite and do the subperiosteal dissection of the gluteal muscle and identify the sciatic notch with our hand. And then insert the screw so that we are above the sciatic notch, because there the gluteal artery will be there and we need to avoid that injury. Now this is an example of a degenerative scoliosis of the lumbar spine, and where we did the fixation from T11 to the ilium. So such cases, this is one more case of osteoporotic spine where we had to include the ilium. So ilium screws are important and it has to be in our armamentarium. Next comes the thoracic pedicle screws. Dead opposite to lumbar. The first thing is again the pars. In lumbar, the pars was forming the medial border of the pedicle. In thoracic, the pars will form the lateral border of the pedicle. So if we know that, just try to identify the transverse process. Start walking from the pars to the topmost part of the transverse process. Just 1 or 2 burr medial to that and burn it, and there will be the pedicle. And one more tip for thoracic pedicle screw is, first after the initial hole, then there will be the pedicle finder. Most of the pedicle finders from the companies, they are thick. That won't give us the tactile feedback. So we need to use the thinnest pedicle finder. The more thin it is easier to go into the pedicle. And if the pedicle probe stops, if you are putting more pressure than 3 fingers, that means we are hitting one of the wall of the pedicle. Then the best way to navigate that is, remove your hand from the pedicle probe, slightly tap with the mallet. So the mallet itself will guide the pedicle probe into the proper position, and then again use the same 3-finger technique to insert the pedicle probe, and then the usual tapping and insertion of the screw goes on. The same technique holds good even for any of the scoliosis or adult surgeries. So coming to the entry point, and the next is again the medial-lateral angulation. Only for T1 and T2 we need to be around 20-25 degree medially angulated. Otherwise, most of them are almost just go by the feel and perpendicular. And superior inferior angulation, there are 2 techniques, whether it's anatomical pedicle or straight through the pedicle. So both of them are okay, they have got enough strength, but the main thing is screw should be in place. So this is one more case of thoracic kyphosis, where the screws are done in freehand pedicle technique, and then the correction has been done. Now cervical lateral mass, again the same, the midpoint of the lateral mass, and then directed superolaterally. C7, sometimes we might have to put in a pedicle screw, and this is important if you have to cross the cervico-thoracic junction. So if the kyphosis or something is secondary to things like tumor, then after the excision of the vertebrectomy, then we need to cross cervico-thoracic junction, we need the cervical lateral mass screws as well as thoracic pedicle screws. Very rarely we need superlateral muscles or as already been dealt with. Now the second thing of scoliosis surgery after inserting the screws is the soft tissue release. So before going to the osteotomies, a very the idea of soft tissue release will give us at least 2-3 degrees of correction at each level. So 2-3 degrees at even 10 levels is around 30 degrees, which is very good. So we need to excise completely the facet capsule and release the interspinous ligament at each level. And ligamental flavectomy is very important. And intertransverse ligamented thoracic spine between the two transverse processes is also to be released. And the rib head can be released if it is a major curve. So ligamental flavectomy is very helpful. We need to drill the inferior half of the superior lamina and drill in such a way that we get the fat, and then trace it laterally, go to the facet and come inferiorly, go to the superior half of the inferior lamina, and from there we can go to the opposite side. This can be used for over-the-top decompression, discectomies and everywhere. Now coming to the osteotomy, quantity osteotomy is enough for us. So if we remove the inferior part of the superior facet and release the facet, that is enough. Along with that, a bit of rib head, that will be enough to get around 5 degrees correction at each level. Then we have medial subtraction or vertebral column resection, which might not be required because most of our curves will get corrected. Coming to the reduction techniques, there is a translation, derotation, inside bending, cantilever, compression, distraction. But the most easiest method which I thought was the differential rod bending and differential rod strength. The concept of this is, on the concave side, they are using a very thick rod which has got more tensile strength like cobalt, and it is more bent. On the convex side, they use thin rod like titanium, and it is less bent. So as and when the correction happens, the titanium takes the shape of the cobalt and the correction becomes easier, because most of the corrections, as said in the historical teaching, comes from the concave side. But using this technique, we can get it from the convex side also. This is one animation video where the scoliosis correction is done by using this differential rod technique. First is the insertion of the screws, as said earlier, by the freehand medical technique. And the second thing is going for the differential materials. On one side, we need to go for cobalt, on the other side, we need to go for the titanium. And on the concave side, it is more bent, and on the convex side, it is less bent. So first we will start on the convex side and start placing what we call it as the crickets. So the crickets are placed on both the sides, and then gradually we will start reduction from the convex side. So this maneuver, everything is happening at each level. The vertebral body derotation, and then translation, cantilever, even the rod derotation, everything is happening at every single level. So the reduction becomes easier, and at the end we are not putting much pressure on the medical screws. So otherwise the screw pull-out strength is more. And this is how at each level it happens, and then it gets corrected. Now this is the summary of my chart: decision before surgery, during surgery. And these are some of the cases. So in this case, we can see there is a scoliosis mid-thoracic, thoracolumbar and proximal thoracic. And the cob angle is 66 degrees, so it's an indication for surgery. And then bending films, we need to include two curves, and fixation is done from T2 to L2. This is second case in which there is a curve of around 68 degrees, so it is an indication. And even there is a mild proximal thoracic curve, so fixation is done from T2 to L2. This is a third case in which there is a mid-thoracic curve and not much of corrector on the lumbar curve, and shoulder discrepancy on bending film, so fixation from T12 to L2, and this is one more thoracic fixation from T4 to L3. So to summarize everything, I just want to give one small thought. Of all the cases that I have seen, mostly the fixation will be from T3 to L2. So if we follow this, I think we can reduce most of the curves. Thank you very much.
The next speaker I call upon, endoscopic transnasal approach to pediatric suprasellar region, institutional experience, Dr. Gautam M.
our institutional experience in managing the cellular supercellular lesions through translucent endoscopic approach in the pediatric population. And at this outset, I would like to thank Professor Ishwar and Prakash Nair sir for permitting me to share this data in front of this great audience. And in the last decade, the endoscopy in the pediatric populations has been having a very great revolution in terms of the better understanding of our skull-based development. And also, there has been very revolution in the technical, either in the terms of instrumentation or in the better endoscopic visualization what we are having. And coming to the patient's data, from 2015 to 2022 of the last year, we have included the patients who had been operated intravenously or through endoscopically for the cellular supercellular lesions, and the target population being the patients of less than 18 years. And the data has been collected from our electronic medical records. And total, our cohort consisted of 53 patients, among which the mean age was 11.63 years, and the gender distribution was equal, and the headache being the most common presentation, followed by visual disturbances and hormonal disturbances. And craniopharyngioma predominated the pathological entity which has been operated, followed by pituitary and glands. And CSF 10 patients constituted CSF rhinorrhea as the primary pathology being operated through endovascular. And again, the same symptomatology in the different pathologies, headache being the most common, as already been told, in craniopharyngioma, pituitary and germ cell tumors, visual disturbances being the most common in glands. And these are the outcomes what we have gone through by operating these patients. Almost 60% of the patients were able to get roster resections, and those patients in gliomas where there was a tight attachment to the optic nerve, where we are only able to get near to functions. And visual improvement was almost seen in more than 50% of the patients we had visual improvement. And complications like meningitis and CSF rhinorrhea were limited to 4.6% of the population. And post-operative hormone replacement and complications like diabetes insipidus were only 53%. And among these patients who required this hormone replacement, it has to be noted that half of these patients already had a preoperative hormonal imbalance, who continue to have this requirement for the hormonal replacement in the post-operative follow-up also. So, when we see these resection limits in individual pathologies, we can see that almost 85% of the patients will be able to get roster dissections when we consider only craniopharyngioma and pituitary tumors. Again, CSF diversion. We required CSF diversion in those patients where there is breach of the arachnoid and extension into the supracellular systems or into the third ventricle. Among which the primary pathology was CSF rhinorrhea. Damodar was used only for the fluorescein dye injection and to see for the vein only, and then the rest of the majority of the requirement was seen in gliomas where the tumor was completely intraarachnoidal. And coming again in different pathologies, visual improvement, as we can see here, the improvement was more with the gliomas and the pituitary tumors. And again, the most common complications which we can encounter in these MS approaches were CSF rhinorrhea and meningitis, even in the pediatric populations where our complication rate was limited to only 4.6%. And there were no any major vascular injuries happened in our study. And based upon the spinal sinus development is very not much developed in the age group of below the 10 years. We have analyzed our patient data into a subgroup where only less than 10 years age group of the patient population has been considered, which included only 16 patients with almost 7 years, 3 months as the mean age group. And average tumor size was around 3.3 centimeters. And in those patients, again, craniopharyngioma predominated this group, and we were able to get almost 63% of the patients with nostril dissection, and visual improvement also
near to 62%. Complication rate were limited to again to 2%. There is one patient had CSF anemia which has been again treated with the Lombard. Thank you. And these are all numbers, and these numbers we cannot see them as only numbers. We can. I would like to conclude that even in a pediatric populations where the spinal cells development is not much and the requirement of the bone relief is more in the area of paraclavicular lesions, very near to the paraclavicular ICA, with the adjuncts, developing adjuncts like neuronavigation, neuronavigation, availability of the Doppler, makes us to reach the tumors with ease. And after some cases, then this advanced technique, advanced adjuncts like neuronavigation will not be required. As you get used to the usual localization and better MRI, preoperative MRI concordance, we will be able to reach, we can use this approach with much ease. Thank you.
Thank you, Dr. Gautam. Next is awaiting craniotomy for eloquent region low-grade glioma section by Dr.
Good morning, everyone. And I'm Dr. Neurosurgery, Cardio Hospital, Stamina. And I did my neurosurgery from Chitra in 2017. And seeing, going to all my senior bosses, Suresh Nair sir, and Matthew sir, Krishna sir, and Prakash Nair sir, everyone. And firstly, in front of everyone is so, giving so much anxiety, it's like viva. But still, I remember what Suresh Nair sir used to say whenever he used to ask me, I can't kill you, but whatever happens, you just stand. Nothing will happen. I can never kill you. So I'm getting some courage. And this is a very small topic. And this away craniotomy is like a old wine in a new bottle, but it is still relevant to the current generation. And when appropriately used, away craniotomy can help us. So the changing landscape, especially in away craniotomy, is because of advances in new anesthesia. We are able to give a very comfortable outcome to the patient. And this man single-handedly, as we know, Dr. R. Kushi, all brought on the mortality. And with the current neuroanesthesia advancements, we are able to give very well controlled anesthesia. And if you see the history of away craniotomy, from 1860s, we started with Broca and localization of cerebral regions. And Sir Victor Horsley tried away brain surgery for epileptic focus in 1886, and Benfield's and Roman's contributions. But the major breakthrough came with 1960s with the advent of neuro-led anesthesia, the chloroquine and fentanyl, and then followed with surgery, sedation and analgesia, and without the need of intubation. And in 1990s, with intravenous anesthesia, that was a major game changer. So when you see the oncological principles in neurosurgery, it is when I especially find this when I present neurosurgical cases in a tumor board where there are radiotherapists and oncologists, they don't seem to understand the oncology where we can plan exactly the cortical incisions. The small cortical incision we are able to take out with less functional lifting. And awake cranial is with frontal region tumors, posterior frontal region will consider motor areas and inferior frontal areas and for speech areas and so far also. Same like occipital region and temporal region. We can name and plan all this preoperatively, and it's especially used to have a neuropsychologist who will sit with the patient preoperatively and do all these tasks one time so that they're used to it. And the same neuropsychologist can be brought to the theater to help with the patient so they are comfortable. And this is the hand area where we can use bipolar direct cortical stimulation to plan a small corticectomy. This is a transcervical approach. And coming to anesthesia, the asleep paradigm is getting more common nowadays, or otherwise called monitored anesthesia technique. So from asleep we are going to awake. So that is more comfortable for the patient. But the patient selection is very important because we need the complete cooperation. So when we place the mayfields, we can give a small propofol sedation, and after clamping, after scalp lock and clamping, and we can plan a small incision with the neural navigation. And training the patient is very important, and I especially felt to have a native speaker, for example for Bengali patients, or a native speaker who can be with the patient, makes them very comfortable and relaxed. And before opening neuro, always infiltrate, because once the patient feels a pain, then it's difficult to get it back. So always go very slow, step by step, and ice counseling always should be there. And this is after clamping and navigation, make the incision as small as possible. And after tube opening, you can make a cortical mapping and plan a small corticectomy. And after final tube resection, you can either give propofol or intravenous anesthesia, or you can continue same experimental infusion and fentanyl infusion. And I'll skip all this. So sensory motor mapping has also helped us a lot. And end of resection, you can always awake craniotomy is the gold standard for confirmation, where we have intact patient in front of us. That gives an maximum reassurance to the surgeon. So risk of pulmonary deficits, they say it's decreased from 19% to less than 2%. And near the speech area, you can always use speech arrest to help. So with all these dual modalities of navigation and tracking. So related contraindications is pediatric patients, especially less than 12, where they are difficult to understand. Large tumors of ventilation, when you open the neuro patient coughs up, there will be ventilation. And existing gross neural networks, there is no justification. And for poor anesthetic fitness. And I'll show a short video. This patient is from, he was from the army, 30-year-old, had a single episode of TTCS and large flight from the gamma insulin until the infant from the virus completely didn't have any functional deficit. So we had discussed, and he didn't want to take any chance, so he opted for awake craniotomy. With the neural navigation, I marked out the margin, and you can grossly see the bunch of denoting low-grade glioma, and there's a binary incision being there. So in this case, there was very clear demarcation in the tumor area and the normal brain. And subcortical stimulation can also be used with low current. So this is the end of resection. You see the anticriminal force of flow.
very good morning to all of you. I would like to thank Dr. Ishwar and all the important faculties for giving me this opportunity to speak in front of you and presenting in front of the watchful eyes of our beloved Professor Suresh is also very gratifying. So, my topic is baby steps in aneurysm surgery. So, what is it about ruptured aneurysms? The treatment is now it has to be done. There is no ambiguity. So that gives certainty to the treatment of aneurysmal subarachnoid hemorrhages. But you might be having, as in neurosurgeons, you might be having that whether I should invest my time and money to learn the microsurgical techniques, microvascular techniques to operate. Well, you are not alone. This is the lament of a vascular surgeon whom you are very familiar with, 2019 paper, where he shows his caseload over the past years, and you will see that this number of aneurysms is coming down. Then he goes on to say, it's disheartening to have climbed the learning curve and published extensively, done extensive research work just to see my practice thinking. But he goes on to say, if I had a chance, I would become a hybrid surgeon. And he has got his fellowship in 2011. We saw Dr. Sunil Fadado eloquently explained the need for a hybrid surgeon, and this issue is settled. My friends and junior colleagues, us vascular surgeons, we have to train both in endo and open vascular techniques. So I want to direct this towards young colleagues and juniors, residents who are just about to start their journey. I presented in the form of notes, mental notes I made to myself every time I made a mistake or made a complication, so that I will not repeat it again. And it is also very economical to learn from others' mistakes than to learn from your own. So the first point, asking for help. So this is a case of a 56-year-old female patient. I did an SAH, patient had previous failure, so we did a MRA first, benign looking picomotory aneurysm. Okay, then there was the aneurysm probably is thrombosed, it's looking slightly bigger in the MRA images. We corrected previous failure, and then I could identify the neck in the angiogram. I thought I could go in and clip it. I went in, the neck was hidden behind the anticlinal process. The stubborn me refused to believe that I cannot dissect the neck. Some blind clipping, the clip went into the neck, ruptured, multiple blind clippings, incomplete aneurysm occlusion. Ultimately, vasospasm and ventilator-associated pneumonia consumed the patient. The next time I was slightly wiser, similar looking picomotory aneurysm, neck very close to the anticlinal process, but I have already asked for backup. I know it is going to be difficult. CT and DSA also shows a nice looking picomotory aneurysm. As soon as I saw this configuration, you can see the neck is buried behind the anticlinal process, and I have marked the ICR also. It is time to call for help from a superior force. So then HOD comes in, intradural clinopectomy, bone drilling, extensive, dural dissection, then the neck is defined. You can see it is much better defined now. Temporary clipping and the aneurysm is clear. So note to self number one, don't hesitate to ask for help. No one knows everything. Second is reading pre-operative images. My friends, I feel like Dr. Suresh showed yesterday, nice 3D images of the angiogram. We should sit in the console the previous day, meditate on those images, and find how the neck is, size of the neck, the line of the aneurysm, and formulate its strategy. So this is a simple example. As you IDH this patient, on axial images, you can see there is an acomotory aneurysm. If you have just seen the scan in passing, you would not have noticed there is a small superior hypophyseal artery aneurysm buried underneath. Since we cannot give antihypertensive therapy after the surgery with an unsecured aneurysm, I was able to clip both these aneurysms and initiate hypertensive therapy post-operatively. So point number two, meditate on your images. It's very important. Now, point number three, adequate exposure. Yesterday we saw Dr. Sanjeev will describe endoscopic approaches to ruptured acomotory aneurysms. Maybe at his level he can do it, but at my level I feel comfortable with a large craniotomy with multiple corridors, not only the Sylvian corridor or also the lateral subfrontal corridor. I'll show one video in this record. Here I am trying to develop the lateral subfrontal corridor. You can see the frontal dura there, up in the upper part of the image, and the frontal lobe below. I try to develop the corridor. There is a bump there. I don't know what sharp forceps, it still hits, scissors, hits the bump again. Then I thought this is not right, something I have not done right, opened again, the cerebral ridges in this patient were very prominent, go back, drill again, make everything flat, and now this looks much better. No, so note to self 3, adequate exposure makes your life very easy. Are you afraid of a full brain? So was I. A full brain is one of our worst nightmares. But over the years, I have learned that with adequate extension with the malar region in the highest point, by opening the assistance and arachnoidal dissections, or by doing a laminar terminalis opening intraoperatively, you can relax the brain. If these are not working, you can always use an EVD intraoperatively to further relax the brain and reduce the load on the retractor that you are using. So, point number 4, brain will relax most of the time. On the topic of brain relaxation, this is a case of acomotory aneurysm patient, DACA aneurysm. Brain was full, I thought should I put an EVD or then I thought we will do a subarachnoid lumbar puncture and do. I was cognizant that I should not drain too much, so the risk of herniation. Then the worst thing happened, surgery went fine, during shifting, got disconnected, lot of CSF drainage, not noticed for a short time, patient became F1, herniated, lost the patient. Okay, so the fear rupture. So this is a case of a hypoplastic A1, that is A1 on only one side. I was prepared on 3D reconstruction. I could see that there is no A1 on one side, but still I knew there might be a small A1. I went inside, anticipating a partial proximal clipping. This is the light of the video. You can see both A2s, ipsilateral A1. I put a temporary clip on the only A1. To my surprise, the adhesion has become less. It is subpermeable to clipping. Now I can let my guards down, knowing that there is complete occlusion with one A1 clipping, and I was able to achieve complete occlusion. This is another example, one of my earlier cases. One of the few cases I did, one of the first cases I did with in the emergency with no one in the campus. So I thought, put 2 clips, both the A1s. I was able to comfortably dissect the neck of the aneurysm. So, note to self number 5. Use temporary clip. The rule is 4 minutes, 10 minutes. 4 minutes clip on, 10 minutes clip off to allow for reperfusion injury. Allow for reperfusion. So, most of the problems I can define, most of my problems I can define with a single point. I used to not define the neck properly. So, here is an example, a case of a nice small acomotory aneurysm. I have put a clip, but it seems the clip has gone through the middle of the fundus because I have not dissected the neck properly. Then again, go dissect the neck. I find a large residual neck. Then I put the second clip. Okay, this is a case of acomotory aneurysm. There is thick thrombus around the aneurysm. So this is the live video, 2 A2s you can see. I am dissecting behind the 2 A2s. It's a closed foot configuration, and I thought I will try some unique clipping. I put a clip between the behind the 2 A2s. Incomplete neck dissection. There was part of neck in front of the ACOM complex. Then I thought I will survey the entire field, and this happens. Then fervently going and clipping, a temporary clipping of both the A1s, and then good old fenestrated clip across the ipsilateral A1. Point number 6, delay your gratification, dissect neck properly. Okay. Point number 7, without going into the details of arthritis and the branching vessels, respecting vessels in the vicinity of the operating field. This is a pre-op image of acomotory aneurysm. A moment of distraction, the ball hook tore the front of your pulmonar, and this is the post-operative image. This is a case of acomotory aneurysm. Surgery went well. Patient developed transient weakness of lower limbs. 3 days later, image showed intercapsule infarct, but I found that took a DSA. Both anteroidals were patent. It's probably an anomalous origin of a perforator or too many perforators that I didn't watch. This is a case of a white neck acomotory aneurysm. Old 76-year-old lady. I had no choice but to clip through the ICA with a fenestrated clip. I made sure I saw the anteroidal and the PCOM, but unfortunately, patient developed a small infarct. But 1 month later, she came walking with a recovery in weakness and recovery in third lobe palsy. This is another image where I'm dissecting an ACOM aneurysm, trying to expose the contralateral A2, then the bipolar coagulates the ipsilateral orbital frontal artery. My mistake. So, point number 7, respect vessels in the vicinity of your surgical field. The Doppler is your friend, my friends. This is a very cheap and a very useful device. This is a case of dark aneurysm. This is the lay of the operating field. I have identified the general proximal and the distal A3s. I am trying to take control of the proximal A3. I put a clip in the proximal A3 and then I use the Doppler to see if it is occluded or not. The Doppler doesn't lie. It says the aneurysm is still flowing. The stubbornly refused to believe, started dissecting the neck, and then what happens? Rupture. I have to put a cotton eye over the aneurysm's fundus and then I have to clip it. So this is a case, a massive IPH with ACH. Patient had a slightly different ICA terminus aneurysm. The ICA aneurysm was arising from underneath the young one. I have already put a clip. And I am surveying how the clip is lying. Clip has covered the neck completely, but the doctor is saying the aneurysm is still filling. Okay, parallel clip across the same. Then the doctor says, okay, you are all right, good to go, no bleed. Okay. Point number 8, Doppler is a cheap alternative. It is your friend, you can use it. Vasospasm, the elephant in the room. Even though you have done nice surgery, nicely clipped, patient succumbs to vasospasm. And this is a small ecom aneurysm. Patient was able to take food, ambulated, again vasospasm. I have tried everything from pockets, irrigation of the cisterns, placing cistern drain, still it is there. Not vasospasm is not the only reason for deterioration in a post-aneurysm patient. This is a case of dark aneurysm. Patient was extubated, post-op scan was good but slightly full. 4 o'clock in the morning, post-op day 2, get a call from ICU, patient has become MFI. Intubate, ventilate because of gross edema. And then as the post-op day 5, you can see the cisterns are just starting to appear. Patient was extubated, discharged with full GCS. So, note to self 9, build your ICU team because you need acute post-operative care to take care of your aneurysm patients. And point number 10, my friends, don't get disheartened by whatever you are seeing. Train, learn, and prepare yourself for the future. Thank you for your time.
I thank all the speakers of this session. But before closing this session, if any comments or any questions to any speakers, they can ask. Yeah, Adit.
I'd like to make a general comment. Basically, I'm so proud that the younger generation believe that we can clip aneurysms. I've spent time with the people from NIMANS. I won't mention names, there are far too many. And I'm really happy that the younger crowd have taken this motion forward. And we have none other than Dr. Rout entering today, who has sown the seeds of aneurysm surgery. This is the first comment. The second comment is India is such a large population that I can't for the life of me imagine that we save one life and we can save 10 lives by using a clip when we're using a coil. Simple maths, simple logic. So I guess we have to keep this skill alive. We also have to make sure that our cost stresses are low. People have forgotten. You must see the patient and say, has he really undergone brain surgery? Come to KM and we'd like to share your proceedings. Thank you.
Thank you. Any other? I think if not, all have understood the brain and the spine, and I think this session was very, very interesting. I thank the organizing committee for making an excellent presentations, and I think all the young generations are both brain and spine, they are doing the surgery. So I thank the organizing team, and I think now we will be having the thank you.
May I invite on stage Dr. Sunil Chandra, Manager, Medical Affairs, Baxter and Drug Surgery, India and Southeast Asia. We will be talking about the role of hemostatic sealant patches in neurosurgical practice. Over to you.
Hi, good afternoon. I'm Dr. Sunil. So I take care of medical affairs for Baxter, India and Southeast Asia. So first of all, I would like to thank Sri Chitra, the entire team, practice. So as a disclosure, I'm an employee of Baxter Healthcare. So we all know that hemostasis and dural sealing, these are very essential procedures when it comes to neurospinal surgeries, right? So because there's a very limited space available anatomically, so this bleeding complication and CSF risk they increases the cost of healthcare system, the length of hospital stay, post-op complications, and then the patient dissatisfaction. So there have been a lot of studies which have been conducted to understand what is the impact of bleeding related complications on the total healthcare cost. So this was a database of 1.5 million patients from US. So where they have seen that in any kind of a spinal surgery, there are almost 15% cases where there is any kind of a there is any kind of a bleeding related complication. So when it comes to the costing part, so the cost, this is the US, this is the US based data. So because I think that's a country which can provide a lot of EMR based data. So based on that data, you can see the cost of spinal surgeries that almost increases by double when any surgery is complicated by bleeding or bleeding related complications. So there's a clear need to minimize the bleeding complications and blood loss, and there should be a structured strategies around that. So we all agree for patient blood management, these are the three pillars. The first one is to optimize the red cell mass, second one is to minimize the blood loss and bleeding, and the third one is to optimize the physiological reserve of anemia. So it's a multidisciplinary approach. So in a patient blood management, I think there's some issue, but in a patient blood management during the intraoperative part, we all know that during intraoperative part there's a clear control of pharmacological or topical hemostats which can prevent bleeding other than the surgical techniques. So there's a long history of development of hemostats. Right from the 20th century, you can see there are very basic things introduced like bone wax, and finally we came up with a very very advanced hemostats like those which contain thrombin or any other kind of clotting factors. So these hemostats, they are very important, and the value that they provide, because they are normally atypical. Because initially there was some discussion happening where we know that we are using electrocautery. Sometimes electrocautery could be dangerous, especially to spine, especially to the spinal cord. So these are normally atypical. They can be used to control bleeding on table and post-op bleeding. They minimize blood loss, improve visualization, save operating time, and then they manage patient on anticoagulants. Also prevent the leakage of body fluids like CSF. So any hemostat should be safe, efficacious, usable. When I say usable, usability means because there are a lot of hemostats and sealants available, but there should be proper applicators also there, so that it should reach the place where we actually want to make it available. It should be cost effective and it should be approved within the country. So there are a lot of different hemostats available. Some of them are containing both the complex hemostasis and sealant. So one of the product is called hemopatch. So I'll be discussing about hemopatch. It is approved as a hemostatic device and surgical sealant. So it's a patch with hemostatic and surgical sealing properties. So this can be used when the conventional surgical techniques are either ineffective or impractical, and it can be used to augment the dural erosion techniques when there is a shrinkage of dura mater. So this is the patch which looks like this. There are two surfaces. So this is the white surface. This is the lower surface. This contains polyphenol glycol coating. So this is the side which is facing towards the tissue, and then there is a collagen pad. The entire body is made of a collagen. And just to give a visual orientation, there are blue dots on the top. So this is just to give an idea to a surgeon that this is a non-tissue facing side, and white side is a tissue facing side. And the squares are 1 centimeter apart from each other. So there are more than 400 different prototypes of this product. So the final product, as you can see, this is a very pliable product and can be easily rollable, foldable also, can be used in endoscopic surgeries. So the mechanism is pretty easy. It contains polyphenol glycol, it interacts with the protein amino acids, and it forms a very strong bond and forms a seal. The moment you apply a hemopatch, it forms a strong seal, and that's the reason it acts as a sealant. And because it contains collagen, because of the collagen, it forms a fibrin cord and inhibits the bleeding. So if you look at the microscopic structure here, there are big pores in the patch. achieve equal level of hemostasis within 2 minutes. So especially, the most important point is especially when there are many cases where you have emergency cases where you don't know or you can't stop the aspirin or octurnal or anticoagulants in those patients, this would be of really useful. So the established sealant is always it's a tissue glue. So this can be used along with tissue glue or it can be used without tissue glue also. So this is a case series of 22 cases where this was used along with tissue glue. So this was used in case of intradermal, it was used in intradural, in extramedullary tumors also, in spine cases also, and in cranial cases also. And there was no leakage. And it was also compared with fibrin glue. So when it was compared with fibrin glue, this actually performed better than a fibrin glue when it comes to serum velocity and CSF leak. So there was a head-to-head comparison. So it's pretty easy to apply. Just cut it into desired shape and size, place it on a tissue, press it for 2 minutes, and then just leave it like that. So within 6 to 8 weeks, it will go away. So I'll just show one application in spinal case and one in a cranial case. So after surgery, first taking the dura. You can measure the size that is required. So you can cut a patch into the particular size. And then just keep a patch over it. Press it with a gentle, press it gently for 2 minutes with a dry gauze. And let it be there. So within 6 to 8 weeks it will be resolved automatically and it won't swell. Similarly, I want to just show the cranial application. So this was a posterior fossa at adenoma. So once the tumor has been resected, so there was no water-tight evaluation possible. So in this case, you can cover it with a patch. You can use multiple patches if the area is big. So you can oppose 2 different patches with a 1 centimeter program. And just press it for 2 minutes and keep it like this. So just to summarize, we know that hemostatic control is very important in case of surgical procedures because it improves visualization and it limits the damage to the surrounding structure. So there are a lot of time which is lost in achieving hemostasis. So hemopatch, as is a soft, thin, pliable patch which is a dual mechanism as a hemostat and as a sealant, and it can be used in surgical procedures for both controlling the bleeding and sealing the dura. Especially when a lot of incidental durotomy sometimes happen, in that case also you can easily use it. So it's a ready to use, just take it out and keep it over there. That's it. Thank you.
Now we will come to the end of the section. May I invite the speakers of the session to kindly come on to the dais to collect their certificates and recognition chair classes. Dr. Raja Kutti, Dr. Sanjeev Kumar Gupta, Dr. Damodar Rout, Dr. Varun Agarwal, Dr. Shashank, Dr. Gautam, Dr. Arun Kumar, and Dr. Gopi witness the conclusion of our conference, the first ever Prof Damodar Rout Oration, elected by Chitra Neurosurgery. To share a few thoughts about this conference, I now invite Professor Nishan Kumar, Associate Medical Superintendent, University Chitra.
Once again, warm good afternoon to one and all. As we reach the end of the academic sessions, I'm sure the journey has just begun. Bonds have reunited, bonds have been made, and it is one of the apt time to remind ourselves that learning never stops. I think that is one proposition which Prof Damodar taught his students, that learning is an ongoing process. Thank you very much, sir, for those words of wisdom to all the youngsters whom you have brought up. And we promise to you that we will live up to what you have taught us. This whole event marks one of the best academic platforms we will be having, so that Trivandrum will be the hub of neurosurgical learning throughout. Thank each and every one. I think the formalities won't matter. It is the interpersonal relationship that matter. And thank you, one and all. This has been a wonderful experience for us also, setting foot on such a path. And I thank all of you to actually bear with us when there were slight moments of difficulty also, maybe due to some technicals. On the whole, I hope it was a wonderful experience for you as it was for us. Thank you.
Thank you, sir. A few words of thanks.
Respected Professor Rout, Madam Rout, senior members of this audience, and colleagues, well-wishers from the institutions, my beloved residents and fellow faculty. I just came to summarize what we went through in the last 3 months when this Damodar Rout oration was conceived, planned and executed over the last 2 days. We have been up against very difficult hurdles to get this through till this moment. I thank Dr. Sanjay Vihari, who, when broached with this idea of Damodar Rout Oration, went through the pains of getting it vetted by the Supreme Decision-Making Authority of the Sri Chitra Neurosurgery, Science and Technology. That is a government body, the institute's governing body. And then came the fund crunch. We were hit by certain restrictions which the government has placed on securing funds for it. And besides, we were very naive. We did not know how to raise funds. That is the truth. And then came the cancellations. People who swore that they will attend pulled out, citing certain personal difficulties. And then the last stroke of misfortune happened 2 days before the conference was to take off, when the orator himself said that his visa had expired when he reached New York airport. And he said he would not be able to come. But fortunately, fortune has favored us. Good luck smiled after some time. And money started flowing in thanks to all the alumni. They chipped in with small and big amounts so that we could stave off a certain financial misfortune that could have happened tomorrow when our creditors start seeking our bills, their bills to be redeemed with money. Thank you, alumni, for chipping in at the right moment. I'm sure that we will be able to reduce or abolish this dependence on external elements to fund the Damodar Oration and related academic activities. I would fail as a human if I don't thank my fellow faculty. KK, please come on stage. George, please come up. Janet, please come up. Prakash. Where is it? Prakash. Ganesh, my treasurer, who has been gone through much harassment in the last few days. Please come up. And last but not least, Gautam. Where are you, Gautam? Come up. And I want to call all my residents who work day in, day out to make this happen. Let me start with the 5 years. Bhushan Akade, Suraj Gopal, Akhilesh Gowda, come up. Lokesh, my second years, Ashutosh, Pooja, who is actually holding the phone back there in the department, Ramakishan Ekandi, Vamsi Reddy, and the first years who were kind of the 9 fellows who joined us 1 month ago, Sagar Bilal, Arvind Prabhu, Nilu, and Ankush Bharati. My solid anchors, Dr. Darshan Ravi, who kind of Darshan Ravi and Srinath. Where is Asif? Asif is there. Asif is a project associate. He's not part of the department, but he worked with us through to make this grand success. And last but not least, thank you one and all. Professor Rout, you are ever, you are the boy, and you will be in our heart always. Not a day our career will pass without you being there. Thank you, sir, for making it all like this, and Madam Rout for supporting it through. I know it's not easy to be his wife, but then you have stood through first and other times you've seen. Thank you very much, one and all the guests who came with just a phone call. Even when we said we have thank you again. And who tears at this point, there is a gush of nostalgia that is happening. And I just can't say, describe it all in words. Thank you again. We'll see you again next year. Please join us for lunch. And we will. Thank you very much. I also have to thank 2 people who were in our department in December, Dr. Arun Gowda Kilera and Anand Binu. They finished their course and left December, but they were part of it.
Thank you, sir. Thank you, madam, for coming and reviving those memories and blessing us once again. Thank you, Ishwar. Thank you, the whole team, for putting up such a great show. We are really pleased and honored to be in your company. God bless you all.
കേട്ടോ പറയട്ടോ അതെയുള്ളൂ ചേട്ടാ